I'll talk without the mic. Yes, yes. So, can you give me diagnosis on this? I need to wake all of you up after lunch. So, if you see this, what would you worry about? Thrombocytopenia, because I'm talking of platelet. Right. So, conditions which produce this. If somebody comes like this to your OPD, what all will you all think of? I'm being very fair here. And these kind of patients will come to you. 100%. No? Yeah. So, if somebody comes like that, somebody said platelet. Nothing, he just come to you and showing you this. Only this. I have to make it a little difficult. ITP, okay. Dengue, malaria. Okay, malaria, okay. Medicine. Malaria will be very sick if he develops such a low platelet count. Okay, very good. Any medicine will be taken. Come again? Rashes and viral fever, yeah. I mean, this is quite good news. Better generally you see milder rashes, but you can, of course. Dengue, okay, yeah. A lot of people are saying dengue. So, to see this, suppose we say it is because of platelet. What do you expect the platelet count to be when you say something like that?
Hello. बराबर से 50 to 70,000.
1.5. Okay. Hello. Yeah. Symptomatic down. So you generally get 18,000. So why specifically 18 and not 15 or 20? Okay, yeah, no, that's good. It's just to get people talking, you know. So the general teaching is when the platelet is below 20,000, you're likely to bleed. Generally. Below 20,000, that's not also. So that's the basis of teaching. Usually below 20 you're more likely to bleed. So whenever we are treating some disorders, we try to think about it.
But then if there is trauma or fever or any injury or inflammation, then you can bleed even about 20. But generally there we keep a cutoff at 50,000 in which you will not bleed. So suppose you want to give clearance for somebody for surgery, you want the platelet to be above 50,000 at least. Suppose you want to put somebody on antiplatelet, you want to keep the platelet above 50,000. Because if you're below 50 and you go and give antiplatelet, he will bleed. Okay? So these are some of the cutoffs which are used and the basis for that. So I was basically doing time pass with that now for the time being. So we get going with cases. So this is the first case for y'all. So these are all who will come to y'all. And this is the kind of patients I picked up for discussion today. So 3-year-old child, ecchymosis. So I told you what petechiae and ecchymosis looks like in that picture. They also have some lymph nodes. You all have examined lymph nodes, hepatosplenomegaly, and this is a number. Platelet is 12,000. Total count is also 12,000. And hemoglobin is 8. Diagnosis.
Come again? Okay. Anybody else? Any other diagnosis? Okay, somebody did a smear. Okay, so here classically high count, white cell count, low platelet. You see lymph nodes, hepatosplenomegaly, typically lymphoproliferative disorder in this child group. Typically ALL is the common. All you have to do is ask for a peripheral smear. You will get a diagnosis. It's full of blast there, clear-cut blast. Nobody will miss this. Simple diagnosis with peripheral smear. Okay, now an older child, 10-year-old, again petechiae ecchymosis. No nodes, no hepatosplenomegaly this time. Platelet count is 12,000, total count 12,000, hemoglobin 8. Same number. But this time no nodes, no hepatosplenomegaly. Viral fever, okay. Usually with viral fever you get leukopenia. Usually. Leukocytosis, little unusual. Generally don't. Previous one, not this one. I won't put the same case twice. Okay. I already did ALL. Okay. Nobody here? So we did the bone marrow for this patient. Okay. So lot of megakaryocytes. All those big, not a great thing pointer, okay. All those big cells which you're seeing there, in the center there. All these big fellows are the megakaryocytes. So in ITP, it will be increased. So the body is trying to produce platelet, but it's getting destroyed in the periphery with antibodies, so the platelet count drops. A lot of them tend to have a little bit of leukocytosis because of either just inflammation or infection kind of thing. Anemia maybe because of a little bit of blood loss and iron deficiency. This is the general scenario where classic only platelet coming down. Sometimes anemia is associated. Sometimes if you have both ITP and autoimmune hemolytic anemia, because antibodies against RBC and platelet, we call it Ivan syndrome, where you can get both. Okay, both can be low. So that's a classic example of immune-mediated destruction. Okay? Okay, so the next one is now an older fellow. 33-year-old again coming with petechiae ecchymosis. This time no nodes, no hepatosplenomegaly. 12,000 platelet, but the WBC here is 1,200, not 12,000. Hemoglobin 8 again. Diagnosis. WBC 1,200. Diagnosis.
Dengue complication.
Come again?
Dengue complication.
Dengue complication, 1,200, 12,000. The patient will be very, very sick. He won't come into OPD at least. To reach these levels, it will take some time, fever. So it will be quite bad. I want to put up this next picture. That's why I'm waiting for it. So basically this is pancytopenia, right? Anemia, leukopenia, thrombocytopenia, pancytopenia. So causes for pancytopenia.
Bone marrow infiltration.
Bone marrow infiltration, aplastic anemia, very good. Anything else? Can you have a cellular marrow? Marrow is full of cells but still pancytopenia. Commonly coming to you all. Pure vegetarian from Gujarat. Okay, very good. So a lot of B12 is present with pancytopenia when it's very severe B12 deficiency, but the bone marrow will be very, very cellular there. Because the body is trying, it's megaloblastic maturation, there's a maturation errors, so it doesn't spill out into the blood, so they can come with pancytopenia. Typically they get macrocytosis. You do a high LDH, B12 will be low when you do this. Yeah, okay, very good. That worked, I think. Okay, so where was I? Yeah, so low count. Now that should be when it's working. Okay, your prayers have worked now. So we are back again to my longest lecture I think I've done so far with 5 slides. Okay, the bone marrow was done. So I showed you the previous bone marrow which is full of cells. This one is looking. What is it? It's empty. So there's no cells at all. It's all totally empty, only fat spaces. So this is typical aplastic anemia. Okay? So aplastic anemia also can come to you with just peticillin. You may come with a little bit of tiredness because of anemia. WBC is low. If they have infection, maybe, but a lot of times they'll just come with thrombocytopenia. So one of the causes for that. Okay, so this is an 18-year-old with rheumatic heart disease. Okay, following up with family physician. No petechiae ecchymosis this time. Okay, he's just come for review to see you, and you've examined him, nothing. But his platelet count is 72,000. Okay, he's got a report with you and he's showing it to you. Giant platelet, very good. So this chap is from northeast, from Bengal. Okay, a lot of people from there have giant platelets which don't get counted on the machine. But when you do the bleeding time, it will be normal. Okay, so they have these large platelets which will not get counted on the machine. So it's a false thrombocytopenia. Okay, next one again back to a 3-year-old. Petechiae ecchymosis is there. Again, like the first time, no nodes, no liver spleen. Platelet this time is 1,20,000. But patient is having petechiae and ecchymosis. Diagnosed. Bleeding time somebody did and it is prolonged. I'll give you the answer. Okay, Glanzmann's thrombostomia. So the platelet is there, but it's dysfunctional. So some receptor defect, so it's not attaching, so thereby bleeding. Okay, last case, 60-year-old. Coming with petechiae ecchymosis, no nodes, no hepatosplenomegaly. These are the numbers. What is the cause? There may be some people in this room also who are on this.
Aspirin.
So aspirin, they won't produce thrombocytopenia, borderline sometimes, but platelet function again. It's a platelet aggregation inhibitor, so they can come with these kind of lesions. Typically, you will see somebody coming and showing me, see, I've got some patch here, what to do kind of thing. So you need to relook at it. So I'll quickly just run through some slides now. I don't want to take too much of your time. I'm also in a hurry. So basically, platelets are very small fragments from the megakaryocyte which are budded off. But you can see they have a lot of function, because a lot of receptors within them, a lot of hormones they interact with, dependent on that. And this is the megakaryocyte which I showed you on some of my previous slides. And then the platelets which are budding off from that is what comes. It's about 3 to 4 microns in size. And this is the structure of the platelet. Very, very complex for something which is so small. You can see the number of receptors on that. There are so many of them. There are so many granules inside. All of them have got a function for platelet aggregation. And if you have a defect in any of them, you can have platelet dysfunction. So normal count, but you can still bleed. Minor bleed, usually mucosal. Their function showed as a cartoon here. You can see when there is injury to the vessel, the platelets will get activated. They will come tethered to the endothelium there, form a nice little platelet plug and seal off the clot. And this happens only when there is injury, not otherwise normal. If you go and clot, the whole body will then go into DIC and clot. So clearly only when there is injury, things get exposed and activate the platelets. So what gets activated is normally there is prostacyclin which is inhibiting the platelets away from the endothelium. When that barrier is broken, thromboxane and ADP get activated, that triggers the platelets all come to the site of injury and seal it off. These are the interactions between the 2B3A receptor and the 1B9 receptor, because these are defects in the disease called Glanzmann's and Bernard-Soulier. This is just an electron microscopic picture to show you what happens to the platelets in the first picture when they're all randomly moving around and when they form a nice little clot. This patient could probably have a bleeding disorder. You need to be a little careful, especially if he's going for surgery. You know, you don't want to go and give clearance for surgery straight away. Now, platelet function and something called platelet activation study. It's just a simple graph where as the platelets only comes down and falls below 1 gram, you can see that bleeding time is prolonged beyond 7 minutes. So as MBBS students, all of us would have done this bleeding time business. You know, if it's done correctly, it's a good test. But most of the time the technicians are not bothered with some bleeding history, you know, because of platelet dysfunction, because of the paraprotein. So quickly I will just run through some of the platelet function disorders. The first one is Bernard-Soulier. It's a receptor defect in the 1B9, so it does not attach to the endothelium, and also with the interaction with von Willebrand factor. And typically you will see patients presenting with larger platelets, typically history of bleeding in spite of a normal platelet count. And these are the giant platelets which I already mentioned, you know, which is also seen in Bernard-Soulier, which you should remember. Then there are storage pool defects, which is a big list of them. I won't go into details of that, but any of the receptor or the platelet granules, if they're defective, you can get mild bleeding disorders presenting as bleeding tendency. Glanzmann, like I mentioned, the receptor is 2B3A. Again, because of interaction between the platelets is not possible, they have bleeding. This is just the theory about that, about platelet dysfunction. Now, acquired. So this is something we should remember. So you must remember in your day-to-day practice, people who are chronic alcoholics on the drugs which I already mentioned, which can be both the NSAIDs or the ADP inhibitors, sometimes antibiotics, and if somebody has heparin, again you can have platelet dysfunction or thrombocytopenia. You must remember that. Now, other than thrombocytopenia, you can also get thrombocytosis, you must remember. Somebody comes with a high platelet count. That is also an equal concern, because a lot of them can come with a heart attack or a stroke because of a high platelet. You know, so you don't want too much of platelet, you don't want too little platelet. Okay? Acquired causes, like I mentioned, immune is ITP, SLE, DIC, drugs, alcohol, malignancies like leukemia, where they present with thrombocytopenia as the initial presentation. Now, some causes for approach to thrombocytopenia. The first time when you get a low platelet count, please cross-check that platelet count always, because sometimes you have giant platelets which are missed. Sometimes there is aggregation in the ADP tube which may not get picked up, you get a falsely low count. Sometimes if somebody has splenomegaly, you will get a low platelet count, which is again part of hypersplenism. Now, when there is a problem within the bone marrow, like in leukemia or any of the myeloproliferative disorders, aplastic anemia or radiation exposure, then all of them can produce thrombocytopenia because of reduction in the production of platelets. Classic example of thrombocytopenia because of increased destruction is ITP, which you already discussed, antibodies against platelet producing destruction and thereby drop in platelet count. And typically other causes which can do a similar kind of thrombocytopenia is in DIC, HUS and TTP, and sometimes in very bad sepsis. Now I'll quickly just run through about ITP because it's a common problem. Typically the initial treatment is all steroids. Sometimes beyond that, if you want to reduce the antibody titers, we give immunoglobulin, splenectomy, and sometimes rituximab, which is a newer drug which is now available for the treatment of ITP. Now another reason for thrombocytopenia in today's world is HIV associated thrombocytopenia, which can be either because of the disease itself or because of the drugs they are on. So you must remember that this can be a cause for thrombocytopenia when somebody is coming with this. Now just one slide just to show you the platelet inhibitors, how they work. You know, you've got selective inhibitors which are COX-2 inhibitors which act only on COX-2, which does not affect the platelet aggregation, whereas drugs like aspirin work on both primarily on COX-1 and thereby inhibit thromboxane production and thereby platelet aggregation. Now these are the various pathways of platelet activation. You can see there are various ways in which can be activated, and drugs have been used to kind of inhibit these pathways to reduce the platelet, aggregability in somebody who has heart attack or a stroke. Platelet function studies are used to make diagnosis of von Willebrand's, Glanzmann, Bernard-Soulier. I don't expect you all to go through this in detail. I've just put this up table just to tell you there is a protocol for this. Now, some questions for you all. What is the trigger for you to transfuse platelets in your patient? When do you want to give some platelets to somebody? Pardon? GI bleed. So any bleeding, but then if the platelet is say 50,000 and still bleeding, will you give platelet?
Less than 10,000.
Less than 10,000, agree? Less than 15,000, okay? Why not 20,000? So anything below 20 and if there's bleeding, definitely you want transfuse platelets. Okay? Because clearly there's an ongoing process of bleeding going on. Otherwise you can wait. So what you will do in dengue, somebody comes with dengue fever, there is data to suggest that you can wait even up to 10 if patient is afebrile, not bleeding and is stable clinically from a hemostatic perspective. No inotropes, none of that. Then you can just wait. But otherwise 20,000 is the cutoff. And normally we give random donor platelet which is about 50 ml, which is derived from one donor. In today's world with machines available, we can do single donor platelet where you get about 300-400 ml from one single donor. So less chances of alloimmunization and higher increment in platelet count. And one STP is equivalent to almost 8 to 10 units of random donor platelet. Okay? So that is what is recommended when you want to transfuse platelets to somebody who has a low platelet. Now I'll just run through coagulation profiles if you're talking about platelet. This is the complex coagulation cascade. It's not the simple extrinsic intrinsic anymore. There's thrombin which acts as the trigger for all this clotting cascade. And the screening tests which are recommended for anybody before they go for any surgical procedure is the simple things which are put down here. It's good to get a CBC to look at platelet count, do a simple bleeding time to rule out platelet dysfunction, PT, APTT, simple tests easily available because sometimes mild von Willebrand or mild hemophilia will get missed and then patient goes and bleeds on table. We've had so many instances where patient goes for tonsillectomy and then they say bleeding doesn't stop at all. Then you realize that APTT was prolonged, nobody's checked, and then the call will come to hematologist saying come and control the bleeding, So it's kind of, something which is preventable. And these are very simple tests available in most places. Every small lab will at least run this much. So it's always worthwhile to do that. Now some algorithm for you all, if all these parameters are normal, you can still have a bleeding problem like platelet dysfunction or factor 13 deficiency. Which means you've done all the screening, everything normal, platelet patient can still have a bleeding disorder. If only the PT is abnormal, it will be factor 7 deficiency or early liver dysfunction. Only the APTT abnormal, it will be hemophilia. Okay, so these are some simple methods to look at how to make a diagnosis. If both APTT abnormal, it will be vitamin K dependent factors, liver dysfunction. So you will need to look at combinations there. Even if the thrombin time is prolonged, heparin liver disease. If everything is abnormal and even the platelet is low, then it is florid DIC. So typically with sepsis in the ICU patient, if you go and do these parameters, this is
symptomatic in the recovery phase of the dengue, and in the follow-up, sometimes we come across that the patient come with a blood report platelets around 12,000 or something, even 10,000. And when we suggest for the platelets or some admission, patient not ready means they are not convinced that we are totally asymptomatic, especially from the lower socio-economic class. Patient is not ready. So is there any protocol if the patient is asymptomatic or not, any serious issues? Can we keep the patient in our OPD and keep on treating patient?
So these guidelines, have come in, some of them from the Western population also, where you have to be, if the patient is in the hospital, you can sit and wait. But if he's roaming around somewhere and cannot get access to a hospital within an hour, then you don't want to take that chance. You would transfuse even at a level below 20,000 just to push it above that because your risk of bleeding is less than that. The worst nightmare is if somebody is in that 10 to 15,000 range and then comes with an intermittent bleed, then you kind of lost that window to treat. So that's what is our recommendation for our country from a realistic perspective. The other side is you don't want to simply go on giving platelet to somebody, okay? Because platelets are precious, there's generally shortage in the blood bank. You don't want to over-transfuse somebody. There are people who had reactions to platelets, and drop blood pressure after platelet transfusion. There have been people who've gone into sepsis also with platelets. Because sometimes when you're collecting, if there's bacterial contamination at the time of collecting platelets, the platelets will sit at 22 to 24 degrees centigrade in a platelet shaker, which is a perfect culture now.
Thank you.
Yeah.
Thank you.
Yeah, please.
Actually, in most of the pre-op investigation, we include only BTC and PD.
Yeah.
So should APD should be
Yes.
included.
So-
the second thing, sir.
Yeah.
Second thing.
Yeah, I'll answer. So, bleeding time has got value. This clotting time is actually obsolete. Nobody does clotting time nowadays, where the question of looking at the flu. It was olden days. So that has got replaced by PT APD. Okay? So PT looks at the extrinsic pathway, PTD is the intrinsic pathway, and then generally they will tell you about the general hemostatic function. So the recommendation for at least CBC, bleeding time, PT APD, that's why I put it up, should be done. Otherwise you will miss mild von Willebrand and mild hemophilia. And it's a very simple test. It's not going to cost too much. It's worthwhile doing for everybody prior to any procedure. It will protect you medico-legally also.
And the patient is on the antiplatelet agents regularly. I think now we see most of the patients are taking aspirin.
Correct.
So should they be protocol-wise? They should be investigated regularly.
So if somebody is on aspirin, generally if they have cardiovascular disease or had a stroke, at least once a year we will tell them get a health checkup done where you must check your CBC. Okay? Because people can drop. See, as you age, there is a higher risk of developing myelodysplastic syndrome and all that, which can start with thrombocytopenia. So at least once a year, definitely we should get it done. If it's a borderline platelet count around 1 lakh, do it more frequently, once in 6 months. Because you don't want to be caught unawares there. Otherwise, there is no need to do anything more frequent than that. When somebody is on multiple, sometimes people get dual antiplatelets. So those are the ones you have to be careful. If they come with any signs of petechiae, sometimes he'll very casually tell you, when I passed urine in the morning, I saw 1 drop of blood. Okay, he may just pass it off, but that may be the first symptom that is telling you that there's some trouble coming up. These are small little things which help. Okay.
So hematology is actually very complicated, and whenever we see CBC, I am giving an example. In year 2014-15, when intravenous iron sucrose was introduced, I think, before maybe there, but I have started giving IV iron sucrose. In one of the patients around 50-60 years of age, having complaint of weakness and tiredness and looks paler. When I do his CBC, hemoglobin was 7. So I advised to give iron sucrose, and I gave 1 dose, 2 doses. And even after 3 doses, he was not improving. But I request that I have seen hemoglobin only. In his case, platelet count was also low, and that was a case of aplastic anemia. And it was the patient was not improving with any iron sucrose. So I request all of you to see the CBC report as a whole, not only hemoglobin or not only white cells only. So
I just add to that, just as knowledge, enhancement, that the cost for the lab to run hemoglobin and CBC is the same. Okay, they're just feeding the tube. So anyway, that report is coming. So please always ask for a full CBC. Don't ask for only hemoglobin ESR, which was the trend earlier. The CBC gives you all that information for the same cost, and it's anyway run on the machine. Okay, and then every anemia with low MCV is not iron deficiency. A lot of people from Gujarat, Rajasthan, Punjab and all that, remember there is thalassemia minor also. So please check for that before you just empirically give iron. So the last 2 statements from me. Okay, thank you.
Thank you, Doctor. And I request Dr. Manoj Kondani to felicitate our today's speaker. Thank you, sir.
Sorry for the long talk.
Now I request Dr. Manoj Kondani to introduce our second speaker, Dr. Aditya Desai, and invite him.
Thank you, Dr. Sharat sir. This was very nice and informative lecture for all of us. Now we are going and moving ahead for our second session, which will be done by Dr. Aditya Desai. Dr. Aditya Desai, we all know, son of Dr. Parimal Desai. We heartily welcome to you on behalf of AFPA. Clapping for sir. Thank you and welcome. He is the director and chief refractive surgeon of Pure Sight Laser Center. He has performed more than 16,000 successful laser procedures by femtosecond laser, that is blade-free LASIK, by control vision correction and trained PRT method. He has also performed more than 5,000 successful cataract surgeries. He is the only one ophthalmologist who is performing ICL implantation and toric ICL implantation at Cure Site Laser Center, which corrects number from -1D to -25D and +1D to +12D in young patient. He is also receiving and he has received the Young Ophthalmologist Award in September 2022 in Milan ICL Expert Meet. His topic is ICL lasers and ICL lenses. We heartily welcome Dr. Aditya. Thank you.
Good afternoon everyone, and thank you so much for having me here on this stage to talk about a few things about ophthalmology. So as sir said that I am a cataract and refractive surgeon, so I'll mostly be talking about the ways by which we can remove refractive errors in patients. So a lot of our doctors are still not much aware about the phakic eye or the ICL, and also the many different types of LASIK surgeries which are done. Now there is not one, there are like 5 generations of LASIK surgeries which are happening. I'll briefly cover all them all and talk to you about the phakic IOL as well. So as we know, the world is now shifting more towards getting rid of refractive errors for multiple reasons, for looks, for the jobs, for sports, for personal reasons. A lot of things. So more and more people, as you know, in your daily practice, they go to Google and search for different things to find out whether how to get rid of things, and instead of we telling them which to go for, they take cover by one. So there are a few things I will go through about the different LASIK so that you have an idea of what's going on in the world. So the first so all the LASIK procedures, mainly I would like to say, is all corneal based. So like we know, the cornea has like 6 layers, and each and every different LASIK procedures are done on different layers of the cornea, which I will explain you shortly. The first generation, the first LASIK surgery which was introduced was the PRK procedure, which we call it as the surface ablation. So surface ablation means we do it on the first layer of the cornea, that is the epithelium. Then the most popular, which is even popular right now, which is the LASIK procedure, which we do it on the third layer of the cornea by creating a flap. And the third generation, which is now relatively popular, is the SMILE. It causes corneal haze, night glare and other problems. So we perform in patients who have less than 5 numbers, or people who have jobs like military, army, for railways, police, etc. And people who have very low corneal thickness. So normally our corneal thickness should be around 500 microns or more. Those people who are less than 460 microns, we go for PRK. But PRK is a bit painful procedure. When the epithelium regenerates, it's extremely painful for the patient for 2 days. And the visual, the perfect vision 6x6 takes about almost 10 to 15 days to come. Then the most popular one, which is the LASIK procedure. The LASIK procedure, like I said, we do it on the third layer of the cornea, which is the stroma. So we create a flap. The LASIK has a wide range of profile that we can correct up to half a number to 10 numbers of myopia, hypermetropia from half to 6 numbers, and astigmatism plus minus half number to 6 numbers. So in order, so the laser surgery is basically divided into 2 parts. That first we have to reach the third layer by creating a flap and then remove the numbers by excimer lasers. So in order to reach the third layer, there are 2 ways. One is via a blade, which is the conventional method. So it's not like a regular blade, it's a small microkeratome blade. It works on micron level. It is mounted upon a machine called a microkeratome, and we create a 270-degree flap in order to reach the third layer. We lift the flap and hence we remove the numbers and put the flap back. And the patient gets vision within 24 hours. And the flap takes about 15 to 20 days to heal. So patient might experience a bit of dryness, night glare issues for 15-20 days, but after that it all becomes nice. So this was the blade. The blade free was an update from the blade. So it uses a technology called a femtosecond laser. It is a cold laser which goes on the third layer of the cornea and creates multiple bubbles and separates the tissue naturally. The best part about femtosecond is that I can control at what depth, what size, what shape flap I want to make, at what direction. Everything we can control with a machine. Since you can see the refractive suite which we use. This is the femtosecond laser machine. First the couch moves towards the femtosecond, we create a flap. And with the excimer laser, after the flap is made, the couch is shifted to the excimer laser and we can remove the numbers with that. This is the exact machine we use in our CureSight Laser Center. We have done about more than 4 lakh surgeries with this. This is a small brief video of how the femtosecond laser works. So we use a suction cone so that the patient doesn't move the eye. After the eye is secured, with the foot pedal, we press the suction button. There is an applanation cone which fits into this suction cone. After the cornea is properly ablated, the machine will show whether the suction is proper or not by showing a green light. Once it is there, you can see I can manipulate the size, shape, the direction of flap which I want to put and everything. And once we are settled with that, we press the laser paddle and the flap is created by creating air bubbles. Once the flap is lifted, we can remove the numbers with excimer laser, and the same way we put the flap back and it heals within a week to 15 days. Another procedure which was quite famous around 2012 to 2016, which was the SMILE procedure. So in this procedure, basically, what we do is we create a lenticule. So lenticule means we don't remove the first and second layer, or we don't touch the first and second layer. The laser is directed straight away on the third layer, which is the stroma, and it creates a small capsule-like thing which we call it as the lenticule. With a side cut on the cornea about 6 mm, with the help of forceps, we just remove the lenticule. So what will happen? The steeper cornea will become flatter, and hence we can remove the numbers. But the SMILE has advantages that no flap, less dryness and everything. But the disadvantages is that it has a very limited profile, that it can only treat myopia. We cannot treat any astigmatic numbers or hypermetropic things. Another thing, it is very expensive and re-surgery, because any LASIK procedure, there is a possibility of getting your numbers back from 5 to 10%. So in this, the re-procedure is not possible. Then now comes the fourth generation, which is right now the most popular, which is the Contour Vision. Contour Vision is not a different machine, but it is kind of a treatment profile. So what it does, it marks your cornea at 22,000 points, and which helps us to create a topo guided, meaning that if I have 4 numbers, if someone has 4 numbers, if we map our cornea at 22,000 points, we all have natural defects in our eyes, which we call it as abrasions. So we'll detect the abrasions and we'll clean it. So this technology actually gives you superior vision. That is more than 6 by 6, which is 6 by 5 or 20 by 10 as we say. So there is a machine called the topolizer, which you can see. So the topolizer we use for mapping, which is directly connected to our excimer laser machine. So the data is fed there and we create a unique treatment for the patient. So the advantage is, like I said, that we can improve the normal vision. We can go beyond that. Night glare, halos and all the problems associated with LASIK are reduced significantly with this. So now the very latest, which has been released in 2023 October, is the Silk procedure. So Silk procedure is a machine ELITA machine by Johnson & Johnson in America. So by this, it is similar to SMILE procedure. I would say it's an upgrade to SMILE procedure. It's a lenticular based procedure. So it takes about 10 minutes of your time, and from the very next day you get about 6 by 5 vision, which in SMILE it used to take about 10 to 15 days. So a small video of how this Silk works. So after explaining the patient not to move and to listen to what they say, we put the patient on the couch. We just look over the treatment profile. Our goal is to create a lenticule like in SMILE. So we use a topic acid and all drops. After that, we just applanate the cone, and there is a radial laser which creates a small lenticular position on the posterior side and now on the anterior side. And since this is done, now we'll shift the patient to another microscope, and similarly we'll dissect the cone with a spatula, and with a forceps we'll just remove the lenticule and remove the numbers. With this procedure, the update is that we can also correct astigmatic numbers and numbers up to -12 as well. So, but as all technology, every technology has its limitations. LASIK cannot be done on thin corneas or who have abnormal topography or very high myopia, more than 12 numbers, or sometimes it is such that we can do LASIK one time, and if the numbers come back, we cannot do re-enhancement. In such cases, phakic IOLs come into play, or popularly known as ICL. So phakic IOLs are basically a small implantable lens which is made up of collamer material, which is the same material our eye is made up of. So we place it just behind the iris, which is the brown part of the eye, and just in front of the natural crystalline lens. The best part is, by this technology we can correct up to half to 20 numbers in myopia, and in biotech company, which is our Indian company, which has an iCRIL lens which can make customized lens up to -30 numbers, and in plus numbers we can correct up to +10. So usually we do it in patients who are from age 20 to 40 years. Since we are not removing the natural crystalline lens, it's not like a cataract surgery. We are just placing it in front of your natural crystalline lens. So your accommodation, after cataract surgery, we lose the accommodation power. In this, we don't lose the accommodation power, so the reading and all the other things are not affected. The advantages of this, I would say the best part about ICL is that implant is at any point in life reversible and replaceable. So if at all, if your numbers change or anything happens, with a 5 to 10 minute operation, I can remove the lens and the eye would become the same which it was before without damaging any part of your eye. Here is a video of I have performed an ICL a few months back. I'll show you how the ICL works. So first we have to load the lens in the injector. So I apply the basic salt solution in it. And the ICL comes in a container. So basically we have to order it according to the patient's size and length. You can see a nice smooth lens shining. We place it on the distal part of the injector. It is very flexible and foldable. So we'll just push it properly and tuck it in the distal part of the cannula. Then with a special forceps, we'll bring the lens to the tip of the injector, as you can see here. After that, we'll put it on the main part of the injector and now we are ready for surgery. So this is a case which I have performed. So we make a side port incision of around 1.8 mm on either side of the eye, which helps us to manipulate the lens and give us stability for it. So using a viscoelastic substance for better visualization. I use this technique, not many doctors use it. It is by continuous irrigation. Many people use a viscoelastic material to maintain the anterior chamber. I use a continuous irrigation substance to maintain the anterior. Like I have made the main port. Now I will just push the lens inside the eye and it will nicely just open up. And with the help of the side ports, I will just tuck it in behind the iris. And that's about it. I will just position the lens properly and we'll just clean all the viscoelastic material with an aspiration port and we're done. It's a very quick 4-minute procedure. It is absolutely painless. There is no sutures, no local anesthesia given. It is done on topical anesthesia as well. And the patient gets result the very next day, 24 hours. The pros, like I said, that it is reversible. The best part which I feel, because if at all any complication, we can remove it. If the patient doesn't like it, they will be the same what they were before. There is no red eyes, no pain, no injection. Since we are not touching the cornea, so no chances for dryness or night glare or any other complications with along with it. So I have a few cases, but since I'm running short of time, I'll just focus on one case which is very unique to us. We did this, a 12-year-old male who came for removing glasses and he had a very high number in his right eye. He had around 24 with 5 numbers, so almost 29 numbers in his right eye. And his left eye he had 7 with -2 cylinders, so almost 9 numbers. So in such case, as we know, even in LASIK, we can do up to just 10 numbers. So, and ICL has its limitations up to 20 numbers. So in this case, we mix match the both procedures. So that process, we call it as bioptics. So most of the numbers in his left eye was corrected firstly. Left eye was corrected by LASIK. The right eye we corrected firstly by implanting the ICL and removed almost up to 20 numbers. At 15-day post-op, he had just around 3.75 to 1.75 numbers. So after 1 month, we did the LASIK procedure on that eye as well and make it e-metropic 0 numbers, and he got a good vision of 6/9 partial.
Sir, 2 minutes left.
Yes. So the newer approaches now coming in 2024 is an ICL for press biopic age group, that is from 40 years to 55 years. So we can now get rid of distance plus reading glasses as well. This is a project which I have been personally working on. That is to change the color of your eyes. So this is a new thing. I went to Paris and met Dr. Ferrari, who was the person who got this He was the pioneer in this surgery, and he has been doing it since 2013. 1 month I took training with him and learned this procedure. In this, we can change the color according to whatever color we want. So it is basically a corneal based procedure. We make a tunnel in the cornea and we apply the dye. And as you can see in the images, it looks very spectacular and nice. So we are still in works with the government for this, and I guess we'll get approval by May. And then if anyone wants to get it done, they can definitely contact us. Thank you so much.
Thank you, Dr. Aditya sir. Any question from anyone? Yes.
My name is Dr. Manohar Devnani.
Hello, sir.
My question is that what is the age at which the LASIK procedure should be done? Generally, we know that age should be 20, 21. One question is there. And second, the other procedures you told about LASIK, what are the costs of each?
So, firstly, the age should be 18 and above, that's fine, or 18 with at least 6 months number should be stable. That person is eligible for LASIK. Best age to do is 20, because by 20 all the growth of the eye and growth of the body stops. So there is no change in the numbers until by 40 we get pressed myopia, which is common to everyone. Nobody can escape because it is an age-related thing. About the cost, all these procedures have different costs. So I would say in our clinic and in the market value, the normal basic surgery starts around 15,000 to 20,000 rupees. If you go for a higher ended thing like a contour revision procedure, which is the fourth and which is popular, it would cost about 40,000 to 85,000 rupees. Smile procedures and silk procedures are even more costlier. They are about 1 lakh to 1,30,000 rupees.
ICL cost?
ICL depends on whether you have a cylinder number or not. So if you have a cylinder number, then a toric lens are costly. It starts from about 60,000 rupees to 1,10,000 rupees.
After ICL, are there any complications or retina effects on retina or
No, sir.
affect the cataracts?
No, sir. Actually, ICL, before we do ICL, there are a lot of checks and a lot of things we do. So there are a set of protocols for it. We check the retina for any thinning or anything. If at all there is thinning in retina, first we do lasers on the retina to curb that thinning, and then only we proceed for ICL. And it all depends on the calculation of your eye. That is, if I tell you technically, it's the anterior chamber depth. So your cornea and your natural crystalline lens, which should be at least 2.8 mm. If it is less than that, then that patient is not eligible for ICL as well. But 90 to 95% of the populations have more than that, so most of them are eligible for ICLs.
Sir, if a patient has thyroid sensitivity, is there any new advances we can do cataract surgery?
Yeah, there are a lot of other anti-anesthetic drugs which are available, by which we can do. Now we do intracameral because we don't give it before surgery. We push it with the cannula with the entry port, and there are very different molecules. If someone is allergic to one, then there are a lot of options out there.
Thank you very much, Dr. Aditya sir. Now I request Dr. Sanjay sir to felicitate Dr. Aditya sir on behalf of AFPA. Thank you once again. Now I request our next chairperson, Dr. R.I. Patel sir, to move for further session.
The third lecture Gaurav Sai is practicing as a consultant diabetologist since 20 years in Bhojpur area. He has attended various international conferences and presented so many papers. He had done active participation in Parnam Registry 2 phases done by Meditronics as an investigator. And today he speaks talk on arterial hypertension. I request Dr. Gaurav Sai to start the topic.
Till my slide sets, I thank you on the Philippines Association for inviting me to speak on this particular topic, and I really appreciate your active participation for this talk. So I'm just given actually some task to talk about the latest updates, what changed in 2023 for 2024 guidelines in our various guideline matters in our previous AC, EASH and all other conferences. So we all know about hypertension and why it is important, what are the priority for India. Because almost so many numbers of hypertensive patients we are seeing, it is increasing and we are getting almost 60 years, which affects overall less than 60-year patient also getting hypertension. And mainly if a patient is hypertensive, then there is 50% of or more chances of mortality with cerebrovascular disorder or cardiovascular disorder. And if we see this chronicity of hypertension is definitely said that it's a proven risk for cerebrovascular and cardiovascular diseases. And 1 out of 4 adult Indian is hypertensive by the 2025 end. So it's almost 214 million till now. So what is the hypertension? We all know numbers. It's 140 by 80. But hypertension, if we say operationally, it is hypertension in the level of arterial blood pressure at which benefits of the intervention exceeds those of inactions. So whatever the benefit we are getting by not controlling the number of blood pressure, we are going to harm our patient. And that's what the new in our line. That there are updated measurements and how we can monitor, and what they say that we need to see our patients in our clinic properly seated, properly maintained, and if a patient is having systolic blood pressure of 140, we can take up to 120, and diastolic blood pressure between 80 and 70. So this is what we need to understand and we need to take care of by monitoring. And this is a review which was showing that recent meta-analysis was proven the treatment part with blood pressure lowering drug in beneficial any blood pressure value. So even if we reduce 140 to 120 or we reduce 160 to 120, we are going to get equal benefit if we reduce the particular point of time. And that's what definition of hypertension changed to. And these are the recommendations for office measurement in our day-to-day life. Like if we need to keep our patients seated with proper arm position, with proper length. So many times what we have seen that we people are not taking care of patient's conditions while patient is not passing urine or patient came up walking very fast to us and we don't let him settle down. And this can increase the blood pressure measurement. And we need to use actually automated electronic or device which is being certified or standardized by the government or the particular situation. So we need to be in a quiet room, we need to keep various sitting position, we need to keep the patient in the office, and we must take 3 readings at a time so that we get a proper diagnosis. And how we can classify the blood pressure measurement. So basically we all know less than 120 milligram and less than 80 milligram diastolic are said as optimal. 120 to 130 and 80 to 84 is said normal. If a patient is having 130 and 139 systolic blood pressure or 80 to 89 diastolic blood pressure, then it is high normal, and anything above 140 up to 160 is grade 1, 160 to 180 is grade 2, more than 180 is grade 3. And if this patient is having just simple systolic hypertension, then it is isolated systolic hypertension, and if the patient is just having only increased diastolic blood pressure of more than 90, then it is isolated diastolic pressure. And this is what is known to all of us. Still, I just mentioned this because there are various changes in the definition and recommendation by various collective reports. Like recommendation says that a BP is classified as optimal, normal, high normal, or grade 1 to 3 according to the blood pressure. And we can, as I said earlier, stage 1, stage 2 and stage C can be decided according to presence of hypertensive, metabolic, mediated organ disorder, diabetes or CKD stage 3 or CVD CKD stage 4. So just this is what ESC 2023 said, that office BP is basis of the hypertension evaluation. We can have home monitoring for most treated individuals and for unique diagnostic method, and we can, if we are not finding proper medication, then we can definitely try ambulatory BP to know how the patient is having DPing or non-DPing in that way. And again, this is a cardiovascular risk according to the grades and stage of hypertension. I'm not going to go into the details of this particularly. Like if patient is having stage 1, it is having less or low risk. If a patient is having stage 3, naturally it is very high risk, and so we need to control those patients aggressively. And what are the various incidences to select the form of hypertension according to the age? And what we find, most of the time we see renal parenchymal disease from any age, from 0 to 100. But if a person's age is almost above 60, then there are the chances of renovascular hypertension. More than 40, we can have monogenic disorder, we can have phlebocytoma or primary aldosteronism. If all are not being there, then naturally we can have it termed as the essential or primary hypertension. So we can diagnose our patients from this BP chart. Like diagnosis established, then we need to start with immediate drug treatment for those patients, and we need to aim for the optimal blood pressure goal for our patient, and we need to inform our patient to have home monitoring of blood pressure measurement or ambulatory blood pressure measurement in the initial part or whenever suppose required. So what's new? That we need to understand that there are expanded lifestyle changes, like role of parent, physical activity and exercise and dietary changes are more important, and we need to tell all our patients to reduce salt, to reduce blood pressure levels, to increase the CV health. We need to increase their overall activity, monitoring and all those things. So lifestyle interventions can be started even from grade 1. Any grade B are requiring this, and it reduces the number of drugs used for the blood pressure management. So how we can, what we can change? Reduce salt, increase potassium consumption. We need to have more stringent on the regard of alcohol intake. It should be avoided if possible, or take as minimum as possible. The level of 1B is there. And if a patient is having hemorrhagic stroke or premature death, then we need to avoid excessive binge drinking to reduce all those things. And strengthening training and reducing the sedentary lifestyle is one of the important aspects. And if we reduce the blood weight, we definitely achieve our goals. So what's new in another part, like simply guidance prescribing pattern or drug treatment, we know. So it's like we need to start with medication. Till now, need to start with one drug, if not controlled, add another, then another, and then another. But in the 2023, what they said, at any point of time, if your blood pressure level is in stage 1 or above, start with dual combination therapy, and in most of our patients, then we need to up titrate to the maximum possible tolerated dose, which gives cardio safety, because now the cardiac safety or a vascular safety is more important as compared to just achieving our numbers in the patients. Then preferably once a daily dose is an ideal thing, but we can increase the numbers if blood pressure is not controlled, and add drug only if needed, and we need to prefer the use of single preferred combination medication. So how we can select our patients? Like we have various drugs, RAS blockers, calcium channel blockers, thiazides, and whatnot, and there has to be inclusion of beta blocker again back to our treatment, which was not there in JNC 7 or JNC 8, but in this 2023 guideline, they have added beta blocker as one of the important drugs, and they have positioned the novel drug in like SGLT2 and mineral receptor antagonist for management of blood pressure related complications. And we need to have the target of office BP management like less than 120 or between less than 130 and less than 80, which is most important to reduce LV dysfunction, CKD or ischemic stroke and all. And in very frail patients, we can target individualized patterns, and we can have slightly on the higher also. So what are various drug classes we know, like S inhibitor or ARBs are the main thing. Then we can have diuretics, or we have calcium channel blocker or a beta blocker. And need to understand that most of the time what we are using is calcium channel or AC or ARB, and the drug which is once a day should be started in these patients. Then there are various other classes in this type of patients. And again, this is another BP lowering strategy in our patients we must follow. Like if a patient is coming to us, gets diagnosed as dual, then we must start with the dual combination therapy. Then if it is dual, then we must use ARBs or CCBs or diuretics, either of the two, and beta blocker can be used if a patient is having younger age or if patient is having any coronary events. And there are various true resistant hypertensions. If a patient was on diuretics, then we need to consider to send to a consultant for hypertension specialist in still not controlled. And this is where what is again I say resistant hypertension is SBP more than 140, diastolic pressure more than 90, and if a patient is on 3 drugs on a maximum tolerable dose where you cannot increase any dose, and if adequate BP control is been not confirmed by ABPM and home blood pressure monitoring also we need to understand, and various causes of pseudo-resistant hypertension should be ruled out before considering it as a resistant hypertension. And so what's new in the 2023 ESC and other guidelines, like there are various innovative treatments like renal denervation therapy, and we also know it can be considered as a treatment of further option where EGFR is at least more than 40 milliliter per minute of 1.732 despite the use of antihypertensive combination drugs. So as I said, we can consider denervation therapy based upon the strategy of the resistant hypertension, and if a CKD stage 1 or 3, up to 1 or 3, we can add spironolactone or mineral receptor antagonist, and we can have also in stage 4 or 5 we can use chlorthalidone or beta blocker, alpha blocker, or a centrally acting agent, and at the end we can have the renal denervation therapy. There are various available, and cardiologists are doing it regularly. Then what are new things and what new treatment algorithms are there for heart failure, chronic kidney disease, and secondary form of hypertension? Like if a patient is having hypertension, and calcium channel blockers is always safe on all those patients, and if there is resistance, naturally we need to go to further step, and SGLT2 inhibitors can be now used with Findron in this type of patients. And so these are the new guidelines what we can do in chronic kidney disease. And if we are having blood pressure with coronary artery disease, like ACE inhibitors or ARBs must be there with calcium channel blocker as a first step. Then we can go with angina, then DHP, CCB can be used, like Rithiazem also. And if there are no angina, then we can go with diuretics. And that's what the target should be, 120 of systolic or 80 diastolic should be there, and the heart rate should be below 80 beats per minute, and that's what is required. If beta blockers are not contraindicated, we must use beta blockers in this type of patients. And this is what a gem of various drugs for the blood pressure lowering, what I talked about. And this is again, if a patient is having heart failure with a positive ejection fraction, then the similar thing, but now the guideline shows that we need to add SGLT2 inhibitors as one of the drug to reduce the ejection, improve the ejection fraction part, and then it's there. Even we can start at step 1, irrespective of patient is diabetic or non-diabetic, we can start those things, and we can consider to substitute the RAS inhibitor by ARNI agent or MRA preferred, particularly if patient is not controlled by 3 of the drugs. And that's where in an atrial fibrillation, this is almost same. Here the beta blocker should be there to reduce the heart rate, and we can have the similar lines, but the target heart rate should be 80 or less in this type of patients to achieve proper blood pressure control as well as to achieve the cardiac safety in those patients. And again, if we go ahead with this, then there are expanded screening to management recommendations. I go somewhat fast, like need to diagnose our patients, initiate the phase, we need to, the first 3 months we can go ahead and then go with short-term follow-up, and we must need to encourage the home BP monitoring to all those 3 patients, and after the first year there is always maintenance of blood pressure and there has to be a long follow-up. According to this particular chart, like various ECGs, cardiograms and what we need to do, there are characteristics of all frequent markers which can decide that what are the hypertensive modified organ damages are there, and according to that we can highlight various treatment plans can be changed. And these are the notable changes in ESA 2023, like confirmation of the definition of classification of hypertension on office BP, upgradation of our office BP measurement whenever possible. Systolic BP target should be 140 to 120, 80 to 70 millimeters, and diastolic is to be maintained, and patient must be enhanced to have higher physical activity and proper diet maintenance, reduce water intake, then allowing to control up to 90% in all our patients. Let's say about this particular molecule. I say for hypertensive should not use, but if at all you want 30 ml is what a guideline says. 60 is slightly high.
Thank you, sir. Now I request Dr. Manoj Kondani to give momentum to Dr. Gaurav Sahib. Please, sir.
Thank you, and now I invite our next speaker, Dr. Mihir Vora. And today we are again very lucky to have another speaker from out of Ahmedabad. Dr. Mihir Vora is a consultant hepatologist working in HN Reliance Hospital, Mumbai. He worked as consultant hepatologist in Global Hospital for 2 years. He presented many cases, abstracts and posters. He was speaker in many conferences and was also co-investigator in NASH and other study. He is regularly visiting at AFPA Hospital and Bankers IVF Center, Ahmedabad, on 3rd Monday of every month. So anyone who wants to take his benefit, they can consult him at AFPA Hospital or Bankers IVF Center. Today, Dr. Mihir Vora will speak on the topic, what is new in hepatology. Welcome, Dr. Mihir.
Thank you, sir, for your words. At the outset, I would like to thank and our gratitude for inviting us to give an update on hepatology. As you all understand, after gastroenterology, there are 3 subspecialties. Somebody does endoscopy, somebody does luminal, and we chose to do hepatology and liver transplant. So it is very important that even after doing gastroenterology, we are part of a very small set. But as we started realizing about hepatology, we realized there are 4 textbooks in hepatology. So it's so common that we have 3 foreign societies, and updates keep on coming, like how you get amazing updates about hypertension. So I thought, rather in 15-20 minutes, what can I go through? So I thought in last 2 years, what new things have happened in hepatology, we go brush up of that so that we are abreast with what we are doing. So we'll try and cover 6 points basically. We try to speak on BIA. We'll update the different new stages of cirrhosis, a different classification. We'll give an idea of what is HUPG and how we are trying to then use fibroscan/MR elastography. Give you update on management of gastric varix, because esophageal varix is very simple. You will see run-of-the-mill things doing there. But what we are doing new in gastric varix management, AKI and cirrhosis, as we understand, the definition keeps on changing year after year, but we have come to a good definition now. And how do you manage coagulopathy? The first 3 lectures were excellent. They gave us a real update of how platelets have been having problems to managing hypertension. Same way I thought I have 1 or 2 cases, but try to cover up things. This is something new which we are doing in hepatology. Why? Because NASH is the biggest problem which we will see. So BI is bioimpedance analysis. Why are we doing this? Basically to understand what is the body composition of person. It uses the principle basically about the flow of electric current by the body. So water, as we understand, is a very good conductor. It has low impedance. Fat is a poor conductor and it will have a very high impedance. So with BI, as now earlier people were using DEXA, we have taken it to another level by doing BIA, and I just updated how does it help us in our management. So this is a chart which we get. A person just stands on the scale. It gives you analysis of the fat, visceral obesity, muscle, how much is the extra water, intracellular and extracellular. So when we are quantifying a person who is obese or a lean NASH, it really tells you that how much muscle they have got and how much is the fat percentage. So to a case for this, 67-year-old female, weight was around 44 kgs, BMI 21, we will call it normal. She was post-liver transplant for cryptogenic chronic liver disease. We never understood what was the cause of her liver disease. She was, after so many years, on a single immunosuppressive agent, tacrolimus. She presented to us with deranged LFTs, enzymes had been 70 by 100. The rest of the LFT was okay. Tacrolimus level after 5 to 7 years of transplant of 5 is excellent. Sonography, her sonography showed she was grade 3 fatty liver. Mind you, BMI is 21, weight is 44. So this is exactly what we will be seeing now, and we call this as lean NASH. So when we did this body impedance analysis, we realized that the person body fat was very significant. Though she was weighing 44 kilos, she had around half of the body which was just fat. Though she was lean and thin, but there was a lot of visceral obesity. So then it just helps us to understand there is a new concept what we call sarcopenic obesity. Whatever the muscle is there, even the muscle has a lot of fat. So just by going with the BMI or the body structure, we may not have been able to identify the cause, and this is where this bioimpedance analysis gives us a very complete description of how we will manage NASH, alcohol and other liver related disorders. Coming to the second part of the talk, stages of liver cirrhosis. So it was very simple in understanding that you may have fat, then you will have swelling, you will progress to fibrosis, and then you will progress to cirrhosis. But if I want a scale which will give me idea about total hypertension, that is the pressure of the liver, and then I want to also understand in terms of complication. So when we use the word compensated, means the person doesn't have any complications. And if I say decompensation, means they have ascites, jaundice, GI bleeding and hepatic encephalopathy. So we wanted some way to have a differentiation of scores plus one definition which can add everything. So to start with, we will use the word chronic liver disease. Why? Because thrombocytopenia, liver was stiff, you did fibroscan or MR elastography and you found that the liver was stiff. To simple understanding, we call this as soft, this is firm, this is hard. So this would be normal liver, fibrotic liver or a cirrhotic liver. It's very easy to try to explain to a person. But add to this when you want to add total hypertension. So a new terminology came which is known as CACL. So it is compensatory advanced chronic liver disease. Then somebody would be compensatory advanced with clinically significant portal hypertension. And then the person will develop decompensated chronic liver disease. So this is a new armamentarium in one of the ways to assess liver disease. Why this came into picture is because we started doing HUPG. In the earlier lectures, as we understood, if we had to monitor blood pressure, you need to take blood pressure and then on the basis decide what medications to give. Same way, if I have to reduce pressure of the liver, but if I don't know what is the pressure of the liver, how do I give beta blockers to try and reduce the portal pressure? Why do you want to do that? So that the varices remain under control, hepatic encephalopathy is better, you don't want to develop ascites. So you try to go through the jugular vein, go inside the liver, there you take the wedge pressure and the free pressure. The difference of the two gives you something known as hepatic venous pressure gradient. Normal pressure is less than 5. Any pressure which is more than 10, you call it clinically significant portal hypertension. the values associated with this gives you idea who will develop ascites, who will develop refractory ascites, who will develop bleeding, which can be detrimental. Add to this, if you add a elastography, just to add a one point, people earlier were using RF, that was through sonography machine, which was like a point of care testing. Same way we use FibroScan, third generation advanced machine, which will give you far accurate values than the RF to understand the stiffness of the liver. So why is this role of transient elastography? Because you can stage, prognosticate, it is very easy to done, it can be done on OPD patients, and it can be like a point of care testing. You can take to the places where I do outreach OPDs. So add the HVPG part for clinically significant portal hypertension and add the FibroScan values. You will come across to this gradient if you can see the cursor. So if my HVPG is 5 and below, I will say normal. So that means they don't have any advanced chronic liver disease, but compensated. Suppose if my value is between 10 and 5, why I say 10? Because I know that person has clinically significant portal pressure. But suppose if I do platelets, if I do APRI score, if I do FIB-4 score and add to this, I know that the risk of bleeding is going to be very less. So it's very important to see the age, HUT, HGPT, look at the platelets because you can calculate APRI score, FIB-4 scores. Along with that, if I have a FibroScan value, I may help in telling the patient, I am okay with you not doing endoscopy as of now, because the risk of bleeding becomes significantly lesser. Let's assume that on the FibroScan, the kilopascal value now crosses 50, and if it is anywhere above 50, going towards 20, going towards 25. The zone between 15 to 25 is the new definition of compensatory advanced chronic liver disease. And if the scores are about 25, we know that this patient has a very stiff liver, he has increased risk of bleeding, their platelets will be below 1,50,000, they have to undergo regular endoscopy screenings, do sonography or MR elastography / and contrast imaging so that they rule out liver cancer also. So this was one of the scores which combined portal hypertension, FibroScan and gave you a good assessment. Now all those things can be done on OPD basis as point of care testing. So we were doing liver stiffness, we then extrapolated to the spleen stiffness. The same probe can be used to see the stiffness of the spleen. The whole world is now trying to add the stiffness of the liver, see the stiffness of the spleen and then take a call. So if my spleen stiffness is less than 21, my risk of portal hypertension is very less. If my score is very high, that rules in favor. My scores less than 40, I know my risk of high varices, bleeding varices, like grade 3, grade 4 or large varices are lesser and lesser. So one out of doing this like a point of care testing gives you a good idea who should be doing endoscopy regularly. The third part of our talk about bleeding gastric varices. Acute bleeding from gastric varices, the standard therapy is doing endoscopic glue injection. You achieve good hemostatic rate, but there is 30% chance of rebleeding in first month. That is why after 4 to 6 weeks of the first glue injection, you want to recheck them. The risk of embolization is around 2%. So you would see this bad gastric varices like a bunch of grapes. Whatever you see outside is just like a Titanic, the iceberg, that what is you just see above the sea. The majority part is in the muscle of the stomach, and there is where the large varices are. So when I can do an EUS guided glue coiling or something, I can do a BRTO procedure. BRTO is balloon retrograde transvenous obliteration of these varices. What I am trying to do through this is that you are going in the varix and injecting the sclerosant. So you go by the femoral vein, you identify the feeder vessel which is supplying these varices, the afferent and the efferent. But you are going through the efferent, injecting the sclerosant agent and causing it to solidify so that the feeders to the gastric varix are controlled. With the help of BRTO, we can eradicate gastric varix. The same procedure can also be done in people who develop lot of hepatic encephalopathy, so that all the feeders which are supplying blood to the brain, which has impure blood, which can make the person sleepy, drowsy, can also be controlled through this procedure. So the use of BRTO has gone beyond when you cannot control a bleeding through endoscopy guided glue coiling, the risk of rebleeding is more or other complications. You may choose a procedure known as BRTO, where even if you have larger varices or the larger feeding vessels, you can try and obliterate through the use of BRTO. In BRTO, we are using a glue, you use a partner. So risk of rebleed is very less, there is no encephalopathy. But suppose if I block these varices, I am trying to tell the system that now blood has to pass through the stiff liver. So the blood which was going away from the liver, because that was God created shunts, but because patient was developing complications, we have tried to block them. Now blood will flow towards the liver. So when blood flow towards the liver, it can increase the risk of esophageal varices and ascites. So before doing this procedure, we will always do an endoscopy, try to obliterate the esophageal varices, and then plan for BRTO, so you don't increase the risk of esophageal bleed. Going to the last part of the talk, where we'll update about HRS and coagulopathy. We were all used to the definition of HRS as type 1 or type 2. Type 1 HRS for us is now acute kidney injury. Type 2 HRS is like a CKD for us, where in type 1 you double the creatinine in a very short period of time. We had multiple definitions, KBICO guidelines, or the various definitions which took into account the baseline creatinine or other complications. We wanted to get the rifle score into picture. All those has been taken together with the help of new societies of nephrology, hepatology and intensive care, and they have come up with this guidelines known as International Club of Ascites, where they look at the baseline creatinine, they will stage them into 1, 2, 3, they look at what will progress, they will assess the response based on terlipressin and albumin. So as we all understand, in cirrhosis our problem is portal hypertension. There is effective low circulating blood flow. It is not that blood is low, it is not the person has bled, but all the capacitant vessels will store the blood. So what you want in treatment is something which will squeeze the blood from this pancreatic circulation and put the blood into systemic circulation. When that thing doesn't happen, people develop hepatorenal syndrome. So this is the exact pathology which has to be reversed, which all of us do with the help of terlipressin and albumin. The most common complication of cirrhosis over time would be ascites, then patient developing renal dysfunction, then patient developing diuretic-induced acute kidney injury, refractory ascites, multiple tappings, and then patient progresses in such a way that needs liver transplant. What can we do early so that you don't cause functional create problem as well as structural creatinine problem? Like initially people will only have functional kidney loss. Gradually over time they will develop structural kidney loss. And that is why this definition helped us to work on this patient faster. We did not wait for the create to go up to 1.5 or 2. Just even 0.3 rise of creatine, you want to admit them, start albumin terlipressin and get the creatine down. Even that 3 to 6 hours drop in urine output should alert you that no, things are not moving forward and you want to treat them faster. So the treatment was withdraw diuretics, treat infection, use albumin terlipressin, and if the patient is developing refractory, you know that this patient will merit a liver transplantation. As we discussed in the first part of the talk about low platelets, the most important part in liver cirrhosis is coagulopathy. All our liver patients have very high INR and very low platelets. But you will be surprised, we have more patients of portal vein thrombosis than patients coming to us with GI bleeding. Why do we say so? Because God has made liver in such a way that there is a balance between anticoagulation and procoagulation. So we call it a balanced circulation. In the early part of compensated cirrhosis, the word is rebalanced hemostasis. Procoagulant factors and anticoagulation factors are more or less balanced in such a way that in early part of compensated cirrhosis, they don't rebleed. A simple example, when patient has acute liver failure, they come with INR of 4 and 5 and 6. In many patients, you will be surprised that enoxaparin has to be given because these patients develop slow flow circulation or they have narrow or atretic portal vein. And that's why the use of enoxaparin has helped in further preventing worsening of liver disease, because which you are able to maintain the flow of blood to the liver. So when you assess coagulation profile in liver cirrhosis, as correctly said by sir, we don't see bleeding time, clotting time. We have to see INR, we may see APTT, platelet count, but more important functional assessment of platelets, fibrogen value, and now our go-to assessment is thromboelastography. A bleeding person, in a person with liver disease, advanced cirrhosis, You cannot assess what is the coagulopathy / bleeding risk in a person if you have not done thromboelastography. Platelet count will be misleading, INR value will be misleading. So we are always used to doing bloods through thromboelastography. Assume somebody has platelets of 1.2 lakhs, has INR of 1.5, and you want to do a liver biopsy. You are not sure whether you want to do a percutaneous method or you want to do a transjugular biopsy. Use of thromboelastography may help you to know whether the graph or the functional assessment of bleeding is under control. And if the graph is good, as we will show in our further diagram, you may ask this person to undergo liver biopsy through percutaneous route. Assume somebody has come to our inpatient with bleeding, but if the thromboelastography is okay, you may not overly transfuse blood products to them to assess the bleeding parameters.
2 minutes left.
Last slide. So in the summary, liver stiffness assessment and spleen assessment are very important tools. You can do this through point of care testing of FibroScan. Optimum treatment of gastric varices is very important, and the anatomy assessment is important, so you can choose BRTO, PARTO, CARTO. Renal assessment is very important. You don't allow patients creatinine to go up to 1.5 and then to react, and the newer definitions help you to optimally time the leak. And we have to remember that liver cirrhosis is a state of balanced circulation, hemostasis, and using unnecessary products is not a good idea. Thank you.
Thank you, Dr. Mihir Bhai. I think you can see the specialization. Dr. Mihir Bhai is specialized, particularly concerned with liver. So he is a hepatologist. I can see that in Gujarat there is no hepatologist, I think. No one is hepatologist. Gastroenterologists are there, but hepatologist.
One of my colleagues have also started. So they are from surgical team. One of my colleagues has just started. We were all practicing in Mumbai together. Many years we studied all together in KM and Science. And one more, Dr. Tanmay, who's come from IIT. So Gujarat is fortunate to have 2 people.
Yeah.
And we regularly come from Mumbai to Ahmedabad, Baroda, Surat, because we have done around 800 transplants. So to maintain them, to manage them, so that as part of outreach OPDs, we are constantly coming there to help for this part. But you are right,
For gastroenterologists, I think 50% of their practice is concerned with liver. So hepatology is a good specialization, and you will have good work also. So I thank. If any question is there.
Why albumin is not given in US?
Albumin is given in US, sir, very much.
You yourself had denied my patient that don't go to US. There you will not be given albumin.
No, sir, albumin is given everywhere. Terlipressin medicine is not available in US. They are available middle. Albumin is available left, right, center, everywhere, sir. It is a tag.
Available means they are not giving that you had advised.
Not really, sir. I don't think that is true.
Okay.
At this stage, we can't.
I request Dr. Ramesh Bhai to felicitate our speaker, Dr. Mihir Bhai. And so we have finished our first session, and as I told, there will be one quiz after each session. So I request to present a quiz, and for quiz there will be a QR code you will see on the screen. You have to scan that QR code and you will get the link. And on the link, opening the link, you will see the question and you have to give the answer quickly. Those who will give quick and correct answer will get the prize. Question will be easy, but you have to read all four answer, and then you have to give the correct answer. A, B, C, D, like that. Not 1, 2, 3, 4. A, B, C, D, right? And those who will give the quick and correct answer will get the prize. You have to scan this QR code, and if you scan this QR code, you will get the link. after getting the link, you will see the question. Roshit bhai, right? You have uploaded the question. Question is uploaded. You can see the question. "25-year-old woman presents with urinary frequency. On examination, she is noted to have a fever." Answer is there. Answer આવી ગયો છે પર કરેક્ટ. અચ્છા ના પણ એટલે આન્સર કોઈ આપી દીધો છે આપણામાં આવી ગયો છે. જેમણે લિંકમાં આન્સર આપી દીધો હશે એ અહીંયા દેખાશે કરેક્ટ આન્સર અને ક્વિક આન્સર આપ્યો હશે એમને. A 25-year-old woman presents with urinary frequency. On examination, she is noted to have a fever and flank tenderness. Which of the following is potential cause of her finding? This is very common we see in our practice. Answers are acute glomerulonephritis, acute pyelonephritis, acute kidney injury and renal cell carcinoma. Correct answer is acute pyelonephritis. Now I see who has given the first answer. Dr. Amit 17461@gmail.com. Dr. Amit Thakur has given the correct and first answer in 9 seconds, and the answer was acute pyelonephritis. So I congratulate Dr. Amit Thakur and I request to give a gift prize. Prize.
You get question.
Okay, we will give a prize to Amit bhai tomorrow. And now our next session we start as we are already late. I request Dr. Chinmay Shah to come on the stage, and I request Dr. Manoj Kodnani to introduce him. Before Dr. Manoj Kodnani introduce Dr. Chinmay bhai, I want to say something about Dr. Chinmay bhai. He has already taken 3 lectures on clinical research in our family physician practice. Many of our doctors are taking tea and coffee, but please take it quickly and please be seated, because Dr. Chinmay Shah is really a good speaker to listen. I request Dr. Manoj bhai to give his introduction.
Thank you. We heartily welcome to Dr. Chinmay Shah sir. Sir is MD and PhD in physiology. He is working as officer on special duty research, DMER, Government of Gujarat, and MEU coordinator and director of IQAC GMC. He is founding editor of National Journal of Integrated Research in Medicine and assessor of NABH for Hospital and NABH for Ethics Committee and QS Kayakalp. He has 18 years of broad teaching experience and conducted more than 150 guest lectures. He served as expert in BPSC and he is member of Central Task Force for updating NEET examination. Today's topic for Dr. Chinmay Shah is clinical research for family physician. Thank you.
બેવાના લેવલનો કેમેરો સેટ નહીં થવા છે.
Please be seated. Please. એક પછી એક લો, સ્નેક્સ બધા લાઈનમાં ના ઉભા રહો અને સ્પીકરને પણ સાંભળો પ્લીઝ.
કહી દો બધાને જઈને કહી દો.
Hello, are you able to hear? I hope you all are able to hear me. Can you just put yes or no in the chat box? We will have our first presentation by one of our participants, and Dr. Sunita start presenting. I would like to bring our next which is present here for the same.
Good afternoon, everyone. આમ તો 4 લેક્ચર થયા છે એટલે થોડુંક આપણને ગ્લુકોઝની જરૂર પડે આટલી બેસવાની આદત ના હોય બરોબર એટલે બેઝિકલી એવું છે કે ફેમિલી ફિઝિશિયન ઇન્ડિયા જેના સેક્રેટરી આપણા પ્રજ્ઞેશ વસરાજની સાહેબ છે એમના દ્વારા છેલ્લા 1 મહિનાથી આમ તો 2 મહિનાથી અલગ અલગ 4 સેશન ઓલ ઓવર ઇન્ડિયા ઓનલાઈન રાખવામાં આવેલા હતા આપને ન્યૂઝ તો ખબર જ હશે કદાચ જોઈન થયા હોય ના થયા હોય તો એમાં 3 સેશન આપણે પતાવીને ચોથા સેશન માટે આજે એમાંથી આપણે 10 કેસ રિપોર્ટ આવેલા અને એમાંથી એક કેસ રિપોર્ટ આપણે એક્સટર્નલ રિવ્યુઅરને મોકલેલા એમાંથી જે સિલેક્ટ થયા છે ડોક્ટર સુનીતા માંગલિકનો તો 5 મિનિટમાં એ એક કેસ પ્રેઝન્ટ કરશે જે આપણે જોઈશું પછી આપણે કોઈ ક્વેશ્ચન એટલે એને પણ લઈશું તો સુનીતા આર યુ ધેર યા યુ આર ઓડિબલ મેડમ કેન યુ સી ધ સ્લાઇડ
Yes, I can see the slide.
Okay, madam. So, over to you, madam.
Okay, thank you, sir. Thank you. So, we go to the next slide. Can we go to the next slide?
Yes.
So, this case is about a male patient. So, you have, yeah. So, earlier, previous one. This is a male patient in his late 70s. And he presented with lower limb tingling and numbness after standing or walking for 25 to 30 minutes followed by fall. Over a period of 2 years, the patient was forced to sit every 10 to 12 minutes, after which he could walk or stand again. So, neurogenic claudication. There was no history of low back pain or radiating pain to the lower limbs, or history of trauma, spinal injury, no bowel or bladder involvement. Next slide, sir.
Yes.
So next one. He was a known case, sorry for the typo error. He was a known case of diabetes, hypertension,
across India, and we have selected this case for presentation. The only objective was that what is the role of family physician in clinical research? ઓકે તો અત્યાર સુધીના લેક્ચરમાં અભી તક કે જો आपके સેશન્સ थे હું ગુજરાતી બોલીશ तो पाछा જે ऑनलाइन ऑडियंस है नहीं समझाए सो अभी तक आपने जो भी सुना वो आपने लोगों से सुना अभी हम जो जानने वाले वो ऐसा है कि आप लोगों को क्या देख सकते हो ठीक है तो पहला मेरा क्वेश्चन ये है कि मेरा टाइटल है क्लिनिकल रिसर्च फॉर फैमिली फिजिशियन सो आई वांट टू आस्क ऑल ऑफ यू व्हाई यू थिंक दैट इट इज रिक्वायर्ड फ्रॉम योर साइड चा पी ली से ग्लूकोज आई गयो हशे सो व्हाई यू थिंक दैट नाउ फैमिली फिजिशियन शुड स्टार्ट involving in the research okay so we have a huge data we can improve our practice and research is a part of innovation or newer guideline
this
okay.
will benefit also patient
it will also benefit the patient now if you look at this slide it shows that recently in news so online also said that physicians are first line of contact. So any patient has any problem, they will first take to the family physician. So if you look at this slide, it says that the situation has become appealing. Fake scientific paper push research credibility to the crisis point. Okay, so what is happening now? That there is a compulsion to lot many people, and people are faking the papers and they are doing it. While family physician is a torch bearer because they don't have to fake because they already have a patient. I was in the just in the afternoon I was discussing that in after the season we in that case we have 100, 150 patients, 200 patients, and in all in slack season also we have 50, 80 patients per day, and it is a huge volume. Okay, so Dr. Pragnesh has thought that let's start this session, and we have 3 sessions till now. So those who are online right now, for them it is like a summary of what we have learned in the 3 sessions. So if you want to do the research, आपको अगर कोई रिसर्च करना है तो क्या होना चाहिए? तो ये ऐसे जो न्यूज़ में आया है कि फेक किया है, ठीक है? तो हम करें तो हमारे लिए ऐसा कुछ न्यूज़ में नहीं आना चाहिए. तो what are the attribute of good research? अच्छा रिसर्च किसको बोलेंगे? तो फर्स्ट ऑफ ऑल प्लान होना चाहिए, कुछ सोच के. फॉर एग्जाम्पल आपके पास बहुत सारे पेशेंट आते हैं और वो सब कॉमन कोल्ड के हैं तो आप सोच सकते हो कि मैं कॉमन कोल्ड पे कुछ करूंगा. देखो हमें ऐसा कुछ करना पड़ेगा कि आपको ज्यादा मेहनत भी ना करनी पड़े फिर भी आप कंट्रीब्यूट कर पाओ क्योंकि ज्यादा मेहनत करनी होगी तो फिर आप नहीं करोगे. ये पेशेंट देखने में से ही बाहर नहीं आ रहा तो रिसर्च कहाँ करेंगे है ना. तो अपने को ऐसा कुछ करना पड़ेगा कि आपका काम भी हो जाए और रिसर्च के साथ साथ अपने आप होता रहे. तो प्लान करना पड़ेगा, क्लियरली डिफाइन करना पड़ेगा. ये स्टार्टिंग के लिए है ना. आपके पास तो बहुत सारे पेशेंट आते होंगे तो उसमें से कोई ना कोई पेशेंट आप डिसाइड करेंगे ये पेशेंट मेरे पास ज्यादा आते हैं, डेली 3-4 पेशेंट तो आ ही जाते हैं तो इसके ऊपर मैं कुछ करता हूँ. ठीक है. और अभी फॉर्चुनेटली ऑडियंस में जितने भी लोग हैं मुझे लगता है जो फाइनेंशियल गेन करना था अब तक सब कर चुके हैं ऐसा मेरा मानना है. जो भी अभी एट प्रेजेंट जो ऑडियंस में है वो लोग तो नाउ दे कैन कंट्रीब्यूट टू द सोसाइटी. देखिए okay so specific as I said that I will work on common cold in adult only not in pediatric. okay तो जब हम डिसाइड करेंगे तो हम फोकस हो जाएंगे कि बाकी सब के लिए ट्रीटमेंट करेंगे लेकिन रिसर्च कंपोनेंट्स हम सिर्फ एक का देखेंगे. आप जो भी कुछ कर रहे हो और जब नेक्स्ट कॉन्फ्रेंस में अगर आप प्रेजेंट कर रहे हो तो 2 लोग पूछ सकते हैं आपको कि ये कैसे किया तो आपके पास आंसर होना चाहिए कैसे किया मतलब इट शुड बी रेप्लिकेबल. ठीक है. अल्टीमेटली कुछ कंक्लूजन तो आना चाहिए. ठीक है. ऐसे ही अपने बात करके छोड़ देने से कुछ नहीं होगा. मिला क्या और 3 डेज में बोलता है ना कहना क्या चाहते हो वो आना चाहिए. ठीक है. एंड दिस लाइन इज इंपॉर्टेंट दो इट इज नॉट सिग्निफिकेंट. कई बार आप दूसरा आपको क्यों ये समझना जरूरी है जूम को कुछ हो गया है भाई जूम बंद हो गया फिर कनेक्ट हो रहा है आप देख लेना. ओके तो दूसरा फैमिली फिजिशियन को क्यों जानना जरूरी है? आपके पास एमआर आते हैं, मेडिकल रिप्रेजेंटेटिव आते हैं और बहुत सारे सर होते रहते हैं और ग्राफ टेबल्स वो सब दिखाते रहते हैं। तो और वो क्या पढ़े होते हैं? बीए, बीकॉम, बीएससी, फिर भी अपने को बोलते हैं सर इतने परसेंट इंक्रीज हुआ, ये हुआ, वो हुआ। तो थोड़ा बहुत हमने रिसर्च जान लिया तो वो हमको बेवकूफ भी नहीं बना सकते, क्योंकि वो सब गेम ऑफ शोइंग यू द ग्राफ, गेम ऑफ शोइंग द डेटा ये है। तो इसलिए भी हमको जानना जरूरी है। ठीक है, अगर हम यहाँ पे देखेंगे तो और
slides are not visible, otherwise it should be. ओके, सॉरी फॉर द टेक्निकल ग्लिच। तो अगर हम आगे देखते हैं तो और एक चीज एथिकल होनी चाहिए। आप कुछ रिसर्च करना चाहते हैं वो एथिकल होना चाहिए। तो प्लांट क्लियरली डिफाइंड, स्पेसिफिक, फोकस, ये सब बात हो गई, लेकिन आप ऐसा कुछ नहीं करो जिससे लोगों को दिक्कत हो या एथिकली लोग अपने को ब्लेम करें। अभी 2019 में एनडीसीटी रूल आया है और 2017 में आईसीएमआर की गाइडलाइन है, तो ये दोनों गाइडलाइन हमको फॉलो करनी है। तो थोड़ी पहले बड़ी बात कर लेते हैं, फिर आपके काम का हो जाए 2 स्लाइड में ही। तो अगर कोई रिसर्च करना है तो क्या स्टेप होगा? तो देयर आर 10 स्टेप। फर्स्ट इज फॉर्मेटिंग रिसर्च क्वेश्चन। ये जो सीनियर लोग हैं उनको पता है कि कई बार ऐसा होता है कि कोई भी गाइडलाइन में कुछ भी लिखा हो, पेशेंट उसके साथ फिट नहीं बैठता है और आप सोचते हो कि आपके एक्सपीरियंस से समथिंग डिफरेंट हो रहा है। तो देयर इज सम गैप, नॉलेज गैप इन द सिस्टम कि भले ही वेस्टर्न कंट्री में लिखा हो ऐसा हो रहा है, लेकिन हमारे पेशेंट को तो ऐसा कुछ नहीं होता है। तो आपको पहले कोई क्वेश्चन डिफाइन करना होगा कि मुझे क्या सर्च करना है या क्या रिसर्च करना है। कि मैंने कॉमन कोल्ड की बात की कि भाई अगर मैं एंटीबायोटिक नहीं देता हूं तो कितने दिन में कॉमन कोल्ड ठीक होता है, और देता हूं तो कितने दिन में होता है। उसके बाद आएगा लिटरेचर सर्च, मतलब हमको कोई दिमाग में थॉट आया तो पहले देखिए कि दुनिया क्या बोलती है। तो गूगल में डालेंगे, गूगल स्कॉलर में डालेंगे, पबमेड में डालेंगे, तो पता चलेगा कि दुनिया इसके बारे में क्या बोल रही है। तो ऐसा पता चले कि हम जो कर रहे हैं वो ऑलरेडी किसी ने नहीं किया है, वरना अगर 50 लोग ऑलरेडी करके बैठे हैं तो हमारे करने का क्या फायदा है, व्हाई टू वेस्ट टाइम। तो इसलिए लिटरेचर सर्च करना है। ये लिटरेचर जो एमआर लेके जाते हैं वो नहीं है, पबमेड और गूगल स्कॉलर के अंदर हम सर्च करेंगे, आर्टिकल सर्च करेंगे। उसके बाद हाइपोथेसिस बनाएंगे कि अगर हम एंटीबायोटिक नहीं देते तो 7 दिन में कॉमन कोल्ड ठीक होता है। ठीक है, उसके बाद आएगा स्टडी डिजाइन। नेक्स्ट स्लाइड में मैं बताता हूँ स्टडी डिजाइन क्या होता है। ठीक है, उसके बाद हम प्लान करेंगे कि कितने पेशेंट लेंगे, कितनी देर तक उनको फॉलोअप लेंगे, क्या देखेंगे, उसको पूरा हम प्रोटोकॉल बोलते हैं कि मैं 20 पेशेंट का करूंगा, 25 पेशेंट का करूंगा, 30 पेशेंट का करूंगा या 2 पेशेंट का करूंगा, कहाँ पे करूंगा। तो दिस ऑल इज नोन एज स्टडी प्रोटोकॉल। उसके बाद ये थोड़ा दिक्कत आती है सबको, यार एथिक्स कमेटी में कहाँ जाने का या रिसर्च कमेटी में कहाँ जाने। तो आज हम जो बात करेंगे वो ऐसी करेंगे कि इसमें कहीं आपको जाना ना पड़े, आपकी ओपीडी में बैठे बैठे आप जो कर पाओ वही हमको करना है, ठीक है। तो उसके बाद डेटा कलेक्ट करेंगे, डेटा एंट्री करेंगे, डेटा एनालिसिस करेंगे, फिर लिखेंगे और फिर बाद में कॉन्फ्रेंस में प्रेजेंट करेंगे। मुझे नहीं लगता कोई एग्री होगा, इतना सारा हम करने के लिए रेडी नहीं है, सही है ना? कितने लोग रेडी है इतना करने के लिए, ये 10 स्टेप? एनीबॉडी? कोई नहीं करेगा कि ये टाइम नहीं है हमारे पास, ठीक है। तो स्टडी डिजाइन में अगर हम देखें तो 2 टाइप की स्टडी डिजाइन है। ऑब्जर्वेशनल, ऑब्जर्व करना है, मैं कुछ उसको करने वाला नहीं, जो भी उसको देखूंगा सिर्फ, और दूसरा है एक्सपेरिमेंट करूंगा। तो ऑब्जर्वेशन में सबसे इजी क्या है? केस रिपोर्ट। तो अभी जो मैडम ने प्रेजेंट किया वो केस रिपोर्ट था, एक केस या मैक्सिमम 2 केस, ठीक है। सो देयर इज केस रिपोर्ट, सेकंड इज केस सीरीज। अगर आप 3 से ज्यादा केस कहीं पे भेजते हो, फॉर एग्जांपल फैमिली फिजिशियन की जर्नल है, आईएमए की जर्नल है और कोई भी जर्नल में 3 से ज्यादा अगर आप केस देखते हो तो इट इज केस सीरीज। उसके बाद अगर अभी मैं एक स्टडी यहाँ पे करूँ कि ये जो हॉल में जितने बैठे हैं उसमें से कितने लोगों ने चाय पिया है और जाग रहे हैं, तो इट इज अ क्रॉस सेक्शनल एट द पॉइंट ऑफ टाइम। अगर ऐसे आप खुद स्टडी करते हो कि आज के दिन में जितने कॉमन कोल्ड के पेशेंट आए वो कौन से एरिया के थे, सिंपल। सो दैट इज अ क्रॉस सेक्शनल। आपको ताज्जुब होगा, कई बार आप नेशनल इंटरनेशनल कॉन्फ्रेंस में जाओगे तो यूएसए, यूके मींस अदर कंट्री वाले बोलेंगे हमने 2 साल में इतने केस देखे। आप आपके फ्रेंड से बात करोगे इतना तो 1 महीने में देख लेता। द प्रॉब्लम विद अस इज वी आर नॉट रिकॉर्डिंग एंड वी आर नॉट रिप्रेजेंटिंग, अदरवाइज द pool of patient which we have is more than what others are doing. Then case control. केस कंट्रोल मतलब आपके पास ही कई लोग ऐसे आते हैं कि भी मुझे एंटीबायोटिक नहीं चाहिए, और कई लोग हैं कि जो लेना चाहते हैं। तो दोनों का अगर आप कंपेयर कर रहे हो तो एक केस हो गया, दूसरा कंट्रोल हो गया। एक पूरे ग्रुप को, आपके कोई फ्रेंड्स है या आपके रूटीन पेशेंट है जो स्मोक कर रहे हैं, कितनी बार समझाने के बाद भी स्मोकिंग चालू ही है। और कई बार होता है ना कि बच्चे का बाप, उसका बाप भी आपके पास आता था, तो इसलिए बाप आ रहा है, उसका बेटा भी आपके पास आएगा। तो पूरा आपके पास एक ग्रुप है, आपके पास जितना कोहॉर्ट है वो किसी के पास नहीं है, ठीक है। तो आपने डिसाइड किया कि मैं स्मोकर्स का सिर्फ डिटेल रखूंगा कि कितने, आज से मैंने डिसाइड किया कि इतने स्मोकर मेरे पास है, इसमें से इतने लोगों का हाइपरटेंशन है, और आप कुछ नहीं कर रहे हो, बस वो जितनी बार आपके पास विजिट में आ रहा है और स्मोक कर रहा है तो आप नोट कर रहे हो उसका बीपी कितना है, ठीक है। ये जो बड़ी बड़ी स्टडी आती है जेसीआई गाइडलाइन और सब, वो किसके बेसिस पे है? इसके बेसिस पे ही है कि 2 साल 5 साल तक लोगों को फॉलो किया। तो आपको एक्स्ट्रा कुछ नहीं करना है, एक ही चीज एक्स्ट्रा करनी है, रिकॉर्ड कीपिंग, उसके बेसिस पे आप सब कर पाओगे, ठीक है। तो दैट इज कोहॉर्ट। अगर एक्सपेरिमेंट करते हो, अभी तक क्या हुआ, सिर्फ ऑब्जर्व किया आपने, कोई नई चीज नहीं की है, जो है वही, लेकिन सर आपने देखा है। तो एक्सपेरिमेंट में क्या है, डिटेल में ज्यादा नहीं जाएंगे। रैंडमाइज कंट्रोल ट्रायल, ये सब आपको सुनाई देगा जब वो एमआर लेके आएगा, तो आरसी किया है। देन नॉन रैंडमाइज कंट्रोल ट्रायल, ये यूजुअली नई ड्रग्स के लिए सब होता है, कम्युनिटी बेस्ड ट्रायल, ठीक है। तो ये सब अलग अलग जाके और अलग अलग मेथोडोलॉजी है जिससे रिसर्च हो सकता है। लेकिन सबसे ज्यादा एविडेंस वाला कौन सा, अगर हमको देखना है, हायरार्की देखनी है, तो दिस इज हायरार्की कि केस रिपोर्ट है वो सबसे बेस में आता है, उसके ऊपर केस सीरीज, देन ओरिजिनल आर्टिकल, देन रैंडमाइज्ड कंट्रोल ट्रायल, उसके बाद सिस्टेमिक रिव्यू, मेटा एनालिसिस, ये सब होता है। लेकिन क्या है, पूरी दुनिया में बहुत सारे प्रॉब्लम है, हम सब सॉल्व नहीं कर सकते, हम जितना कर सकते हैं उतना करें। तो केस रिपोर्ट हमारे बस की बात है, तो लेट्स डू इट, ठीक है। तो आप क्यों करोगे और आपके लिए इजी क्यों है, ये दूसरा क्वेश्चन। हमने जो पहले डिस्कस किया, आप यूजुअली ये 7 या 8 आपके पास कॉम्पिटेंसी है, आपके पास जो लोग आते हैं, तो यू आर डूइंग अ प्राइमरी केयर मैनेजमेंट, यू आर आल्सो हैव अ ओरिएंटेशन ऑफ कम्युनिटी, आपके आसपास क्या लोग हैं, कैसे लोग हैं, ठीक है। देन आपको पता है कौन सी नस, मींस पब्लिक की नस कौन सी है, यू नो द नर्व्स, तो यू कैन सॉल्व द स्पेसिफिक प्रॉब्लम कि इसको ऐसे ही हैंडल करना पड़ेगा, दूसरा बाहर से आएगा तो वो हैंडल नहीं होगा। Then you also have a comprehensive approach, 1 2 3 चीज, जैसे मैडम ने एक और हम केस रिपोर्ट मिला था कि they are using yoga practice and Ayurvedic preparation and everything, you are doing that also, so you do comprehensive approach। Then 80% पेशेंट को आप नाम से जानते होंगे, ठीक है, जो फ्रीक्वेंटली आता है, और आपको गुजराती में आप कि तासीर खबर हो आपने, so that also you know, and holistic, कई बार उसका फैमिली प्रॉब्लम भी आप सॉल्व कर देते हो, बच्चे का पढ़ाई है, बच्चे का ट्यूशन है, बच्चे का शादी है, वहां तक हो जाता है, तो यू आर कंसीडर एज ए होलिस्टिक गाइड फॉर एनी फैमिली, सो दे विल आल्सो रिवील एवरीथिंग विथ यू। कई बार ऐसा होता है कि बड़ी बड़ी रिसर्च में चीजें छुपाते हैं, तो ये सब आपकी कैरेक्टरिस्टिक है, इसलिए भी अगर जब फैमिली फिजिशियन अगर रिसर्च में इन्वॉल्व होंगे तो डेटा अपना खुद का मिलेगा। अगर अभी हम विटामिन डी निकालेंगे हम सबका तो 80% का कम आएगा, क्यों? One of the reason is the data is not from Indian origin. Okay, हम आउट बाहर से लिया है, तो अगर आप ये स्टार्ट करोगे सिर्फ केस रिपोर्ट तो पता चलेगा कि हम कहाँ पे हैं, ठीक है? तो ये थोड़ी स्लाइड से स्किप कर रहा हूँ कि हमने टाइम ऑलरेडी आप लोगों को ज्यादा हो चुका है, तो क्योंकि आपके पास ये 8 कैरेक्टरिस्टिक है तो आप रिसर्च में ज्यादा इन्वॉल्व हो सकते हो। आपको क्या करना पड़ेगा? What you have to do? You have to simply change the goal. अभी तक मैं सिर्फ पेशेंट देखता था, अभी मैं रिसर्च में थोड़ा इन्वॉल्व होऊंगा, ये डिसाइड करना पड़ेगा। एक बार आप डिसाइड करोगे तो नेक्स्ट क्या होगा? You have to develop the habit of reflection. रिफ्लेक्शन मतलब अभी तक क्या करते थे, पेशेंट आया, दवाई दी, बात खत्म। रिफ्लेक्शन हम सबकॉन्शियसली तो करते ही है, आप लोग जब मिलते होंगे तो बात तो करते हैं ना कि लास्ट महीने में इतने सारे पेशेंट आए, समझ में नहीं आया ऐसा क्यों हुआ, या ये टाइप के पेशेंट अभी ज्यादा बढ़ गए हैं, तो आपने थोड़ा तो सोचा ही होगा। तो रिफ्लेक्शन एक्चुअली क्या है? तो रिफ्लेक्शन में आपने 3 क्वेश्चन का आंसर देना है, क्या हुआ, सो व्हाट, और आगे क्या करेंगे। अगर ये 3 चीज, ये नॉट ओनली इन प्रोफेशनल लाइफ, इन पर्सनल लाइफ आल्सो, व्हेनेवर वी आर हैविंग एनी प्रॉब्लम वी हैव टू आंसर दिस 3 क्वेश्चंस, व्हाट हैपेंड, सो व्हाट एंड व्हाट नेक्स्ट, ठीक है? अगर इसका आंसर हमारे पास है तो वी आर रिफ्लेक्टिंग प्रॉपर्ली। दूसरा क्या करना पड़ेगा? Improving the quality of evidence-based practice. तीसरा, nurturing personal area of interest. मैंने जैसे बोला हर एक का अपना पर्सनल इंटरेस्ट होता है, तो वो आप डिसाइड करके उसके ऊपर रिसर्च प्लान कर सकते हो। उसमें कंटिन्यू रखना पड़ेगा, अभी उम्र हो गई, अभी नहीं करना है, तो अगर उम्र हो गई है सही बात है, तो पेशेंट केयर थोड़ा कम करेंगे, रिसर्च में ज्यादा जाएंगे, क्योंकि आपके पास एक्सपीरियंस है जो कोई स्कूल में पढ़ाता नहीं है, IIM में भी वो नहीं पढ़ाता है, और या एम्स में भी वो मिलता नहीं है जो आपके पास है, ठीक है? एंड ट्राई टू डेवलप अ लिंक विद द लेमैन, लिंक विद द कंसल्टेंट। अभी तक सिर्फ पेशेंट के लिए रहते थे, अभी रिसर्च को ध्यान में रख के भी आप कर सकते हैं। तो ये जो जितनी बातें हमने की वो यहाँ पे चेंज करने की बात है, ठीक है? जब तक मेंटालिटी अपना लुकआउट नहीं चेंज होगा आप रिसर्च में नहीं आ सकते, तो इतना आपको चेंज करना पड़ेगा। एक बार ये हो गया तो उसके बाद आपको 5 स्टेप में आगे बढ़ना है। नंबर 1 ऑब्जर्वेशन करते ही आप, लेकिन अभी कॉन्शियसली करना है, कई बार सबकॉन्शियस ऑब्जर्वेशन तो हो ही जाता है। क्या हो रहा है? आस्क योरसेल्फ अ क्वेश्चन एंड इफ यू आर नॉट एबल टू आंसर इट, आस्क समबडी एल्स नियर बाय। जैसे हमने बोला रिफ्लेक्ट करो उसके ऊपर। द नेक्स्ट इज एक्सप्लोर लिटरेचर सर्च, एज आई सेड पबमेड, गूगल स्कॉलर, यहाँ पे भी करना है। और बाद में आपका क्वेश्चन डिफाइन करो कि ओके ये सब करने के बाद मुझे पता चला कि इसका आंसर हमको नहीं मिल रहा है, तो ये 5 स्टेप में आप पास होंगे। ऑब्जर्व करेंगे, पूछेंगे 2 लोगों को, मुझे ये ऐसा लग रहा है, आपको ये रूटीन होता है ना, जब कोई भी रेयर डिजीज होता है तो वो भी यूजुअली स्टार्ट फैमिली फिजिशियन से होता है कि वो अगर ऑब्जर्वेंट है तो वो आइडेंटिफाई कर पाएंगे। क्योंकि क्या होता है, जैसे जैसे हम ऊपर जाते हैं उसका फोकस नैरो होता जाता है। आप ही हो कि जो पेशेंट को एज ए होलसम देखते हो, अगर उसको हेडेक भी है तो एब्डोमिनल प्रॉब्लम भी हो सकता है, और अगर वो न्यूरोलॉजिस्ट के पास गया तो डायरेक्ट सीटी स्कैन एमआरआई होने वाला है, ठीक है? तो यू आर द पीपल, यू आर द पर्सन हु नो हिम एज ए होल, not as a separate part. So I urge all of you to involve in the research. So what is next? The next is you have to define yourself how you would like to explore the problem, how you will collect the data. लेकिन फिर भी जब ये सब बातें आएगी तो आप सोचोगे यार फिर से डेटा कौन कलेक्ट करेगा? How many of you are using online software for OPD? So those who are using online software, they don't have to collect. It is already recorded. आपको सिर्फ 1-2 महीने के बाद उसका डेटा एनालाइज करना है. सिंपल मैं स्टडी आपको बोलता हूँ. मेरे पास जितने पेशेंट है उसमें से कितने मेल थे, कितने फीमेल थे, कितने लोगों को कितने दिन में फॉलो अप लिया और क्या ट्रीटमेंट है. इतने से स्टार्ट करो. जो आपके पास डेटा है उससे स्टार्ट करो. आपको पता चलेगा कि आपके पास तो खजाना है. एथिकल रिव्यू, अगर आप ओरिजिनल रिसर्च या ऐसा कोई बड़ा करना चाहते हैं तो एथिकल रिव्यू इज मस्ट. देयर आर एथिक्स कमिटी इन मेडिकल कॉलेजेस एंड बिग हॉस्पिटल्स. वी विल नॉट इंडल्ज इनटू इट. एंड फाइनली रिपोर्ट द रिजल्ट. जैसे मैडम ने आज प्रेजेंट किया है, लाइक दैट शेयर द रिजल्ट विद पीपल इन द कॉन्फ्रेंस इन द जर्नल. ओके, आपके पास चैलेंजेस क्या है? व्हाट आर द चैलेंजेस विद यू? अगर मैं बोलूं ये सब करना है तो व्हाट आर द चैलेंजेस यू हैव? एक तो लिखने की दिक्कत है, टाइम नहीं है, फिर इंफ्रास्ट्रक्चर नहीं है. दोस हु आर ऑनलाइन आल्सो कैन आंसर. व्हाट प्रॉब्लम यू आर फेसिंग? Okay, so these are the problem. Am I right? Lack of time, lack of interest, lack of money for research, lack of teaching program or materials. मुझे रिसर्च करना है लेकिन कोई समझाएगा तो ना. ठीक है, गाइडेंस नहीं है. यस, लैक ऑफ इंटरेस्ट, रोल मॉडल्स, मेंटर्स. अगर जैसे मैडम ने प्रेजेंट किया, ऐसे जितने भी केस रिपोर्ट है, मैं परमेश भाई को बोलूंगा कि ग्रेजुअली वी कैन पब्लिश दिस ऑल केस रिपोर्ट इन फैमिली फिजिशियन जर्नल. तो अगर 10 लोगों को देखेंगे हम तो पता चलेगा कि ये कर रहे तो चलो हम भी करते हैं. तो देन वी विल गो इनटू द रेस. लैक ऑफ रिसर्च डायरेक्टर, कंसल्टेंट एंड लैक ऑफ कॉम्पिटेंट सॉफ्टवेयर. तो क्या करें? आप बड़ी बड़ी बातें करते हो और इसमें से हमारे पास कुछ नहीं है, क्या करें? तो इसीलिए फिर से मैं वहीं आऊंगा. द परफेक्ट फिट इज केस रिपोर्ट. क्यों? हाई वॉल्यूम ऑफ पेशेंट, आपके पास बहुत सारे पेशेंट आते हैं और कई लोगों के फाइंडिंग रिपोर्टेबल होते हैं. और अभी मुझे लगता है मेरे बाद का जो सेशन है, अगर हम वो सेशन को ठीक से इंटरप्रेट करेंगे और इंप्लीमेंट करेंगे तो आपकी केस रिपोर्ट तो अपने आप बन रहेगी. बरोबर है साहब? एबीडीएम નો ઉપયોગ જો બધા કરવા માંડશે તો બધા પેશન્ટનો ડેટા સેન્ટ્રલ લેવલે સર્વર ઉપર આવી ગયો છે. બરોબર? તો હાઈ વોલ્યુમ ઓફ પેશન્ટ યુ હેવ, સમ ઓફ whom have a reportable finding. Second is easy to do. અને ત્રીજી અને અગત્યની વાત, third and important, no ethical permission is required. Only permission from patient is required. आपको कोई कमिटी में नहीं जाना है, कहीं पे भी नहीं जाना है. सिर्फ पेशेंट को पूछना है और उसकी कंसेंट लेनी है कि भाई तेरा मैं रिपोर्ट प्रेजेंट कर रहा हूँ. अगर तेरा फोटोग्राफी डालूंगा तो आइडेंटिफाई नहीं होगा, ऐसा वो ब्लैक पट्टी लगा के. तो इतना ही हमको करना है. तो आई रिक्वेस्ट स्टार्ट विद द केस रिपोर्ट. तो क्या करोगे आप? Look for the good case, read, do the literature review, obtain the consent from the patient. जैसे मैडम ने सब रिपोर्ट आपने देखा ना, एमआरआई और सब किया था. तो he is a family physician. He underwent everything and finally came to the conclusion, if required, involve the consultant and identify the journal where you can submit your case report. Okay? So, what you should do? Tell your story of your patient. हम ऐसे ही बात करते हैं. Let's document, start documenting it. Get the details which is correct. Employ the pictures or figures wherever relevant. Formulate title. आप कुछ केस है उसका कुछ तो टाइटल डालना पड़ेगा. A newer case of this or a rare case like this. And important, seek your written consent from the patient. और आपको क्या नहीं करना है? होमवर्क के किए बिना केस रिपोर्ट नहीं, वरना फिर 10 क्वेश्चन खड़े होंगे. सो डू प्रॉपर होमवर्क. डोंट पब्लिश केस रिपोर्ट विदाउट कंसेंट ऑफ पेशेंट. कल मैं कोर्ट में जा सकते कि मेरे को बिना पूछे मेरा इमेज यहाँ पे डाल दिया. एंड डोंट इंक्लूड एवरीथिंग. मुझे इतना सारा पता है, सब कुछ डालने की जरूरत नहीं है. जो इंपॉर्टेंट फीचर है वही डालिए. द समरी इज ऑलवेज कीप योर आईज ओपन फॉर एन इंटरेस्टिंग केस. Verify by the literature search Write. Seek advice from the others who are publishing. Submit, revision if needed, and if the first you don't succeed, try again. Okay? So, Sir William Osler ने ऐसा कुछ कहा है कि always note and record the unusual, publish it, place it on a permanent record as a short, concise note. Such communications are always valuable. Thank you.
Thank you, Dr. Chinmay sir. Now I request Dr. Sanjay sir to felicitate Dr. Chinmay sir.
So before we end, we would like to thank online participants also. Parenthesis bhai.
Thank you. Now I request Dr. R.I. Patel sir to introduce our next speaker. Thank you.
ડૉક્ટર ચિન્મયભાઈ જે ફેમિલી ફિઝિશિયનને રિસર્ચ માટે ઇન્સિસ્ટ કરે છે ખરેખર એ સારી વસ્તુ છે. આપણે બધા એબોવ 50 યર્સવાળા છે અને એમણે કીધું કે કોમ્પ્યુટરને આ બધું હોવું જરૂરી છે, પણ કોમ્પ્યુટર ના હોય તો લખીને પણ રાખો. અને હવે ઈચ્છા છે કે આપણે આપણા AFPAમાં પણ થોડા કેસ પ્રેઝન્ટેશન કરીએ અને એ કેસ પ્રેઝન્ટેશન તમે જેવા પણ કરો ને એવા કરો. એવું હોય તો 2 જણની ફેમિલી ફિઝિશિયનમાં સલાહ લઈને તમારા કેસ પ્રેઝન્ટ કરો તો એમાં મજા આવશે, ઇન્ટરેક્શન રહેશે. એટલે હું રિક્વેસ્ટ કરું છું
એમાં એવું શરૂ કરો કે જે કેસ પ્રેઝન્ટ કરશે ને એને 20%, 25%, 50% રજિસ્ટ્રેશન ફીમાં ડિસ્કાઉન્ટ. કારણ કે આપણે અલ્ટિમેટલી ગુજરાતી ને.
આજે હવે નેક્સ્ટ સ્પીકર આવે છે, એમનું ઇન્ટ્રોડક્શન તો ડોક્ટર R.I. પટેલ આપે છે. પણ એ પહેલા હું તમને કહી દઉં કે જે લેક્ચરનો ટોપિક છે એનું નામ છે ABDM. કદાચ તમે જાણતા હશો, આયુષ્માન ભારત ડિજિટલ મિશન, કે જે નરેન્દ્રભાઈ મોદી નવા તુક્કાઓ લાવે છે, જે એ આપણા હેલ્થમાં આ એક નવો તુક્કો છે. અને એ ABDM શું છે, ABDM થી હેલ્થમાં શું નવા ઇમ્પ્રુવમેન્ટ આવવાના છે, એ અંગે આપણને ડોક્ટર મિસ્ટર ભૃગુરાજભાઈ ત્રિવેદી ઇન્ટ્રોડક્શન ડોક્ટર R.I. પટેલ આપશે અને મિસ્ટર ભૃગુરાજભાઈ આપણને એના વિશે સમજાવશે.
થેન્ક યુ સંજયભાઈ. મિસ્ટર ભૃગુરાજ ત્રિવેદી is a joint director in Ayushman Bharat Digital Mission and a state nodal officer in National Health Mission, Health and Family Welfare Department, Gujarat State. He is a BE, MBA and certified project management professional. PMI USA, he has extensive experience in field of e-governance, dashboard, public administration, project manager and data analytics. Now I request Mr. Bhruguraj Trivedi to deliver a note on evening video.
એક હતું સાહેબે જે કીધું કે નરેન્દ્ર મોદી સાહેબના તુક્કાઓ છે, તુક્કા શબ્દ બહુ ખરાબ વસ્તુ આવે, તુક્કા ના કહેવાય.
સારો વિચાર છે અને
તુક્કા શબ્દ શેમાં વપરાય છે?
સારો વિચાર ન હોય.
You are right. અને હવે નરેન્દ્ર મોદી માટે તો
અરે ગમે તેને માટે તુક્કા નથી. આ કરશે તો કોક દાડો ફાયદો થશે. અમેરિકા એમને ઉપર પહોંચ્યું નથી.
સંજયભાઈ 1 મિનિટ બ્રેક જઈ આવો ને, પતી જશે. જેને જવું હોય છે, ના જોડે જવું હોય જઈ આવો, કન્ટિન્યુ રાખો. ઓલરેડી 4:45 થવા
એના પર રિસર્ચ કરો.
Dr. Chinmay for being the foundation for the Ayushman Bharat Digital Mission funda or the mission that the Honorable Prime Minister Sir has launched. So just to begin with, when he was RCM, he used to encourage all of us. ગુજરાતી હિન્દી ઇંગ્લિશ બધું કમ્ફર્ટેબલ છે ને હું કદાચ ગુજરાતીમાં વચ્ચે આવી જાઉં બોલતા બોલતા કારણ કે સ્વાભાવિક માતૃભાષા છે એટલે ઉર્દુ સિવાય બધું હે ઉર્દુ સિવાય બધું એ મારે શીખવાની બાકી છે ત્રણ ભાષા આવડે છે અત્યારે તો સર as we are going live we prefer Hindi or English wonderful yes I'll try to stick to that so when he was our chief minister he used to encourage us to use technology for betterment of fellow citizens be it for the ration card, for the ration, be it for the revenue. For ration card, I'll give you an example from the supply chain point of view, from the go down to the fair price shops. What is the status of the food trays? What is the availability? What is the shipment status? Or say, for example, revenue, where your file is residing right now. Green channel, yellow channel, red channel, the file is with which officer for how many days. So at your fingertip you will be able to identify the pendency, not just as an administrator but as a citizen as well. So taking it gradually, how technology can be useful in the healthcare sector. So that is where the idea or vision of Ayushman Bharat Digital Mission came. We all have gone through the pains of Corona. And in that scenario or in that time, if we had some technology, a common denominator where we can have access to each and every citizen's healthcare data, the scenario might have been something different than what we have faced. So the insistence by Honorable Prime Minister is the cost or the money that we are expending in the healthcare sector, in the technology is an investment. It's not an expenditure, but it's an investment. So with that foundation, reform, perform and transforms triangle, the Ayushman Bharat Digital Mission was envisaged. And we all are aware about the digital India, what transformation it has brought to the nation. When we talk about digitization, I used to narrate this story in early 90s. I am aware about this scenario, so you all must be well aware of this. When the digitization was introduced in banking sector, many of the people were opposing it strongly. Data would be trapped, the jobs will not be there, so on and so forth. So all fears were there. But you see the transformation of the financial sector. If we go to a child, scan the QR code and transfer the amount. Many a times we go to, say for example, in the morning to get some milk or grocery store. Generally, we don't use the hard money. Is there any exception? We are all used to have that technology. We don't know the chai wala, so it's very obvious that we don't know the name, we don't know the account number of that person. But still we trust the technology and we transfer the amount. So that way, it will help us. Wouldn't it be useful, I just scan the QR code of a health facility or a doctor's clinic and my health record would be transferred available to the doctor's system and he has access to my entire health data, health only. Wouldn't that be useful as a physician to all of you? Isn't it? So that sort of transformation it is envisaged and we have very much implemented at many places. So this is how the Ayushman Bharat Digital Mission has been envisaged. So this is the basic umbrella of Ayushman Bharat. It has 4 components. It starts with the preventive mechanism. There is Ayushman Bharat Health and Wellness Center. Then we have the secondary tertiary treatment through the Pradhan Mantri Jan Arogya Yojana, where we can have the treatment up to 10 lakh rupees in our state. Then the Ayushman Bharat infrastructure mechanism to equip the health and wellness centers and the PMJY hospitals in the government sector. And the ABDM works as a fine thread to connect all these pearls. So this is how the Ayushman Bharat Digital Mission is covering all the initiatives or all the health sector's facilities. It is basically a citizen-centric system with the state-of-the-art technology where we can have the storage of data, distribution of data in more quality way. It helps us in collecting data with better validation, better verification. So quality of data of course improves. The USP of this entire program is interoperability. Now there are multiple physicians, practitioners sitting in the system, and many of you may be using different systems, isn't it? Many hospitals, nursing homes or private labs, they may have different systems and it is too obvious. So as a citizen or say practitioners or fraternity at large, wouldn't it be useful if these entities, systems can talk with each other, can exchange the data? So this is the USP of this entire mechanism, platform for interoperability. Then comes about the data. Data is of live human beings, so it should be updated, it should be accurate. So it will help us of having updated, accurate data. And on administrative aspect, if you are having some mission or if you are having some goals, say for example the SDG 2030 goal set up by the WHO or by the government of India. So we'll be able to measure whether we are heading in correct directions or not. Do we need any realignments? Do we need any corrective measures during the course of time? So it will help us.
There is a special announcement. There are 2 cars which are just opposite the gate, and other cars won't be able to move. Speaking this number of the car GJ01RM5655. If somebody who is part of this hall, please do something, do the needful at downstairs. And another car GJ01AR2513. Is there anybody from the hall? Kindly raise your hand. Nobody? Okay. Sorry. Kindly proceed for the further session, sir. Thank you.
So it will help us in assessing the status where we are and where we are heading. So basically, the mission started with the vision of inclusiveness. It is inclusive for all citizens, entire population of country, say for example, entire population of state, 6.5 crore. Accessible, it should be accessible very easily, as easy as say for example we are using the UPI or say WhatsApp or Facebook on our mobile. It should be affordable at the same time, it should not have any added cost to that. The system must be efficient, it should not have additional time or processing time into that. It should be timely, say for example when we visit ATM and when we swipe our card, it gives spontaneous outcome. The system should be behaving like that, it should give us data spontaneously, and the most important part, the data should be safe and secure. So this is the major concern of many practitioners, most of the citizens, that what is about the security of the data. So let me narrate this and assure the gathering. The system is based on consent. So unless and until consent is given by the citizen, the data will not be shared. And the difference between the Indian health digital system and the other Western countries system is, in India, citizen is the owner of the data. So data is not shared with any entity, be it central government, be it state government or any practitioner. Unless and until the consent is shared, data is not, consent is given, data is not shared with anyone. As we all know, the relationship between the doctor and patient is based on trust, isn't it? And the pillar of this entire mechanism or the mission is security, confidentiality and privacy. The talks, the discussions or the exchange of information resides between these 2 entities, the doctor and the patient. So unless and until there is consent from the citizen, the data will not be shared. it is voluntary. Anybody can opt in at any time, anybody can opt out at any time. Wellness is at heart. So wellness centric program is there. The single source of truth helps in many ways. Government in special, we may ask for data and multiple agencies provide data. So when we compile the data, there is a lot of discrepancy. So when we are having single source of truth, then we have consistent data. You may also feel that when you are getting data from different sources, you may have variation in that. So that would be again useful when we are having single source of truth, where we can access data on a common platform, interoperability. Federated architecture is the data resides where it is originated. Say for example, I have consulted one physician in Baroda and the data is generated in Baroda. The data resides in that clinic or in that nursing home only. It is not pushed to central government or state government. I as a user, I link that data with my user ID, which is called AFPA, and when I visit another physician or another lab, or for that sake if I visit to any pharmacy store, I can give my AFPA number, I can give consent, and then based on my AFPA number, the data which is generated in Baroda may be accessed on read-only mode. So it is very much secure, and accessibility for this data is also for a certain period of time. So the time window is also defined and user can always manage the consent. And standard framework, the framework is very helpful in rolling out the mission across all the states. And as I have said, open APIs and interoperability, that is the USP of the entire mission. So these all stakeholders, it is envisaged to onboard them. The citizens are at the center of the mechanism. It includes all doctors, it includes all Ayush practitioners, it includes the nursing staff up to the pharmacy stores. It also talks about the NGOs, the research organizations. It talks about the policymakers, the legislators, say for example various authorities, say for example NHA, SHA, Food and Drugs Authority, so on and so forth. So these are the basic architectures or the building blocks of ABDM ecosystem. As you can see, ABHA, HPR and HFR, these are the three basic building blocks. And on left hand side, you can see is health information providers, from where the data is provided. On right hand side, you are having the consumers, health information users, where data is consumed. But the rectangle that you show in between, it works as the check and balance algorithm, where the consent is checked. So unless and until the consent is received, it is authenticated, the exchange will not take place. Who can be the health information provider? Any government digital health system may be a health information provider. Any private integrated health information system, it can be also a health information provider. Citizen itself can also be an information provider when he is giving data with the physician or say with the lab. And health locker, where the citizens' data or any other data stored and may be accessed based on the consent, may also be a health information provider. Same way, it may be used at various hospitals, be it the government hospitals or private hospitals. It may be used by citizens as well, storing data, linking on the private health record application and health locker as well. So these are 5 foundation steps. Ayushman Bharat Health Account ABHA is the first step to join with the ABDM, where a citizen can open an account and link the health records. The second step or the second block is Healthcare Professional Registry, HPR, where the qualified doctors, super specialty doctors, Ayush practitioners, be it homeopathy, Ayurveda, Siddha, Unani, they can also join. Qualified nurse staff, they can also join and register in HPR. Health Facility Registry, a small clinic, mid-sized nursing home, super specialty hospital, digitization centers, pharmacy stores, they can also register in HFR. Then comes the ABHA mobile app. It is available on Android and Apple both. And UHI, Unified Health Interface, which will help in exchange of data. Ayushman Bharat Health Account, ABHA. ABHA is nothing but a 14-digit random number. The gathering, if they start generating ABHA, then everybody will get random number. It's not a sequenced number. Everybody will get a unique number. So it is very hard to predict the ABHA number. Generally, it is generated from either from Aadhaar or from driving license. The easiest way is from Aadhaar. You can just need to key in your Aadhaar number. It will send an OTP for authentication on your registered mobile number. You need to key in your OTP and your ABHA number is generated. It takes lesser time than what I have narrated. It takes just 20 to 25 seconds based on, of course, your typing skill. But it takes 20 to 25 seconds to generate ABHA. And based on Aadhaar, you don't need to type anything else. It will fetch your name, date of birth, your gender, your address, registered mobile number, registered email ID, your photograph, whatever details available in Aadhaar, it will be fetched from Aadhaar. And if there are any updates in Aadhaar, you can always do the eKYC. You have the access of ABHA, and at any given point of time, you can update your details. So what is the fun in having ABHA? So individual can link the health records with ABHA and can be accessed across India from Jammu Kashmir to Tamil Nadu, from Gujarat to Arunachal Pradesh. It's very seamless. It is very easy to sign up. Anybody can voluntarily opt in, anybody can opt out at any time. It's very easy to remember. If we forget, we can retrieve it from either mobile number or from Aadhaar number. It's very easy. And I would like to reiterate, it is consent-based access. So unless and until, as a citizen, if I give access to physician, to healthcare professional, then only data will be accessible to the entity. Unless and until the citizen gives the consent, data cannot be accessed. So this is what the approach we are having. The government is targeting 100% population to cover with the ABHA. 100% family inclusion. We are having multiple programs going on in government machinery. So we are targeting that to include, to cover our citizens. Government machinery, we also have our own limitations to expedite, to cover citizens on faster speed. We are also approaching to different departments, different NGOs. They are also helping us out. Say for example, we are working with Department of Science and Technology. We are working with Women and Child Department. There are multiple NGOs, say for example, Chamber of Commerce. Then there are many blood banks who are doing volunteer services. So all these organizations, they are also supporting us wholeheartedly. And the target is to cover 100% population with ABHA. So these are the applications through which we can generate ABHA. There are multiple other applications as well, but these are the dominant ones which are used in Gujarat. PMJY, Pradhan Mantri Jan Arogya Yojana, Ayushman Card, the COVID, TECO application for RCH, then non-communicable diseases, e-Sanjeevani telemedicine platform, Nikshay application for TB elimination program, Paytm as a, say for example, private application. So there are multiple agencies through which ABHA may be generated. There is a QR code displayed on the screen. You just need to scan the QR code, key in your Aadhaar number, key in your OTP, your ABHA is ready. The QR code is also available on the pamphlets shared with you in the yellow pamphlet. I think it is not there in this updated one. આમાં ભાઈ સાઉન્ડ ચાલે છે?
એટલે કે આભાર. આયુષ્માન ભારત હેલ્થ એકાઉન્ટ એટલે કે આભા એક એવી સુવિધા છે જે તમામ મેડિકલ રેકોર્ડ ડિજિટલી સ્ટોર કરશે. આ વિગતો તમારા ડોક્ટર સાથે પણ શેર કરી શકો છો અને ઓનલાઈન એપોઇન્ટમેન્ટ થકી મળશે લાંબી લાઈનથી મુક્તિ. આ QR કોડ સ્કેન કરી અથવા www.aptm.gov.in વેબસાઇટ પર જઈ જાતે જ આભા નંબર બનાવો.
प्रणाम ताऊ जी। अरे क्या हुआ, इतने परेशान क्यों लग रहे हो? अरे बेटा, मेरी एक्सरे रिपोर्ट नहीं मिल रही, कल डॉक्टर के यहाँ जाना है। अगर रिपोर्ट नहीं मिली तो वो फिर से एक्सरे करवाने के लिए बोल देगा, फिर से पैसे खर्च करने पड़ेंगे। अरे ताऊ जी, लगता है आपने आभा अकाउंट नहीं बनाया है। हैं? कौन सा अकाउंट और इससे मेरी रिपोर्ट का क्या लेना देना? अरे ताऊ जी, आप आओ, बैठो। सरकार की एक नई स्कीम के अंदर आप आभा यानी आयुष्मान भारत हेल्थ अकाउंट बना सकते हैं। इस आभा अकाउंट से अपनी रिपोर्ट, डॉक्टर की पर्ची, हॉस्पिटल वाले दस्तावेज जैसी सभी जानकारियां फोन में ही रख सकते हैं। जरूरत पड़ने पर फोन से ही डॉक्टर को भेज भी सकते हैं। ये करने से रिपोर्ट ढूंढने का झंझट भी खत्म और दोबारा कोई एक्सरे या अन्य जांच करवाने से भी बचेंगे। वाह बेटा, ये तो बहुत बढ़िया है। अच्छा ये बताओ, मेरा आभा अकाउंट बनेगा कैसे? और तेरी ताई का भी बन जाएगा क्या? अरे लाओ ताऊ, अपना और ताई दोनों का आधार दो, आप दोनों का आभा अभी बना देता हूँ। बस abha.abdm.gov.in से आधार नंबर के माध्यम से तुरंत ही आभा बना सकते हैं। हमने और हमारे परिवार में सभी ने अपना आभा बनाया है। आप भी आभा बनाओ, डिजिटल हो जाओ।
There is one more benefit I would like to bring it to your attention. I was narrating about using the QR code and exchange of data. Wouldn't that be useful? So let me take you to the place where we are using it. And in fact, I am very glad to share it with you. We are having 19 medical colleges associated with the colleges and hospitals. And all these 19 hospitals, we are having scan and share facility functional. So you can visit any of these 19 hospitals. This is the video of one of the hospital in Delhi.
Now you can skip the long queues at OPD counters and generate your tokens instantly. Want to know how? Continue watching. This is the OPD counters area at Government Hospital in New Delhi. Every day, thousands of patients stand in these queues. ABDM comes into the picture. ABDM brings to you a simple functionality of QR. A patient can simply scan the QR code placed near the registration desk using their phone. Select the app from the list displayed on screen. Register or log in to share their profile with the hospital to complete the OPD registration digitally. On successful sharing, the patient gets their token number on the app. When the token is called or displayed at the counter, the patient simply visits the registration desk. The patient is asked some basic questions related to their health issues, and the outpatient slip or OP slip is given to them. The patient can now visit the doctor and complete their consultation. By skipping the long queue at the OPD counter, the patient saves time and efforts. Apart from this, under the ABDM scheme, the patients also get the benefit of digital health records. With faster OPD registration and digital health records, the patient gets dual benefits. For next consultation, they can simply walk in, take the OPD token and share previous health records from their app. No need to carry medical files.
So wouldn't that be useful if we can simply scan the QR code? We can have the availability of data, and at the same time OPD token may be shared with the patient. Or say for example, I take it to the next step. Citizen can take an appointment of your clinic. The arrival of citizen is known to you. The medical records of the expected citizen, it is known to you. Wouldn't that be very useful as a practitioner, that you are having the details of the expected patient? So for example, Rugraj is expected to visit your clinic, and whether he is having the blood pressure or the sugar or the thyroid, so on and so forth. So as a practitioner, you may be better equipped and you can devote more time in other qualitative assessment. Basic details if you are available at your fingertip. So that is the beauty of the technology. Another part, say for example, when we talk about the IT system, seamless system. So from OPD to treatment to say for example, settlement of claim, entire cycle will get integrated. So Bhruguraj Trivedi, it's very difficult name. मेरे बुआ जी ने मुझे नहीं पूछा था कि आपका नाम क्या होना चाहिए. So मैं जितने भी लोगों को मिलता हूँ, they spell my name differently. So as a citizen, I am expected that I will key in my name correctly. So as a doctor, you are not concerned with the name of the patient. You will treat it based on the illness. But for the insurance company, Bhruguraj Trivedi, if you skip H and make Bhruguraj, तो उनके लिए एक अलग बंदा हो जाता है. तो वो पकड़ेगा कि आपके आधार में ये लिखा है, आपके ड्राइविंग लाइसेंस में ये है, आपके वोटर आईडी में ये लिखा है, लेकिन आपने जो कागज दिखाया है उसमें Bhruguraj लिखा है, Bhruguraj नहीं लिखा है. Hence your claim is rejected. And the poor Bhruguraj will not go to the claim office. He'll approach the doctors or the nursing home कि मेरा claim क्यों reject हुआ. So it's an added headache for the practitioner. And by and large, this is the maximum time consuming or the effort consuming activity in entire day. So it will again help in having the seamless transaction. It will help in reducing such cases by and large. The other two aspects is HPR and HFR. Let me narrate you how it works. You may see in various parts of cities across our country, 100% Sachot Nidan, Siddh Yogi. And if you ask what is your qualification or from where you have studied, you will not find the data. Many times we read in newspapers frequently that malpractice, a person found doing malpractices. So reliability is a question mark in today's time. So wouldn't it be useful if we can get a platform where we can have a trusted source from where we can get the list of practitioners? So ABDM is such platform where we can get the trusted, verified list of practitioners, health facilities operating in the region, operating in that locality. So it will help us in better visibility. It will provide a reliable source, trusted source, verified data. It is available on internet, so the reach out or the searchability is very good. HPR HFR will help in having a seamless transaction, availability of health records of patient to the doctor. And again, it will reduce the operational cost. Say for example, the tussle with the patients for such cases of insurance. It will help us in avoiding such cases. So this is some of the benefits for HFR and HPR. This is how the process works. The practitioner keying the data. If it is a government practitioner, it will go to the work verifier in the government system nominated by the state government. For private practitioner, it will go to the respective medical councils for verification, and based on the data available, the application will be verified. And once it is approved, it will go to the public domain. Let me tell you one thing. Submitting of application and approval of application takes great amount of time. So we are almost 11,000 applications approved, but against that we are having more than 20,000 applications received. So every application is minutely scrutinized, it is minutely assessed, and only when they are satisfied, the application is approved. So it is something like that. It is minutely checked, and once it is cross-verified with the existing database, with the existing list, then only the application is approved. And these are the steps of applying for HPR. It is again, you need to key in your Aadhaar number, it will generate an HP ID, healthcare professional ID. Once HP ID is generated, you need to upload your educational qualification details. One more thing is available there. If you are having council number and data is available in digitized form in the council, the majority of applications will be deemed approved based on the algorithm. The application number, the name of the applicant, other demographic details keyed in the council, and the data available from Aadhaar and educational qualification and the keying details. If it is matched, the data or the application is deemed approved. So you need to upload your educational qualification and the work experience. If it is a government practitioner, then you need to upload the latest order and then you need to submit it. Now there is also provision. There may be many details that one may not wish to have in public domain. Say for example, I don't want to have my mobile number in public domain, or I don't wish to have my photograph in public domain. We can uncheck these details and those details would not be published in public domain. So that facility is also available, and once the application is submitted and notification is sent to the registered mobile number, and the application is sent to the concerned with the medical council or with the government practitioners. This is how the health facility registry works. The facility manager keys the data, it goes to the work verifier or the district verifier, and then it goes to the state nodal. And once the data is verified, then only it is approved. So these are the benefits, as I said. The entire facility may be seamless transaction, better searchability, a reliable source. A very good initiative by Government of India, which was launched during the G20 in Gujarat, is Heal by India. So Heal by India provides a platform for persons from other countries. If they wish to visit India as medical tourism, then APDM will provide one of the platform for searching the health facilities, doctors as a reliable source. So I actually wish to bring it to your attention that Heal by India is one of the initiatives by Government of India under the medical tourism. Another part is the Digital Health Incentive Scheme, DHIS, where the Government of India pays 20 rupees per transaction. Per patient per transaction. Prerequisite is patient should have ABHA and the facility should have the ABDM enabled software. Of course, the doctor should have the HP and facility should be registered in HFR. Not required to tell. So these are the prerequisites, but per patient per transaction 20 rupees will be given to the health facility directly. So for example, Bhruguraj really visits to Sir's clinic and he prescribes something. So that is a single transaction. Then say again there is a blood report, 20 rupees. If there is say urine report, 20 rupees. So as many health transaction takes place, the incentive is directly deposited to the health facility. And this is by the Government of India to the health facilities. Same way it is applicable for the diagnostic labs facilities as well. If there are IT companies, systems who are developing multiple HMIs, say PHR, EMR, they are also eligible for the incentive 5 rupees per transaction. So I request you all to please register yourself in DHIS. It is a very good initiative and Government of India is directly paying incentive to the practitioners, the facilities. This is what the status is. There are a lot of concerns, anxiety among citizens, among practitioners, among various stakeholders, but I am very glad to share with you. Today we are having more than 60% population covered in Gujarat. 4 crore 31 lakh 49,000, 48,000, it must be 50,000 now. So 4 crore 31 lakh citizens already covered in AFPA so far in our state. 10,000 plus professionals, they are registered in applications are received. And more than 14,000 applications of health facilities are also registered with us. Almost 100% health facilities of government is registered. Almost 100% PMJY empaneled hospitals, they are also registered. Many NGOs, PPP, private practitioners, they have also joined. And I request you all to get on board on this digitized mechanism, digital mode. It will help you in manifold, and this is what going to happen in next few years. And the pace at which the country opted Aadhaar, let me tell you, the adoption of AFPA is far more speedier. Maybe it is one of the byproduct of Corona. People have started adopting, embracing the technology, and they are onboarding and they are using the AFPA and linking health records. More than 1 crore 50 lakh health records are also linked with the ABDM platform. So this was all from my side. I would love to hear something from you. If there is any doubts, any queries, any feedback from your side, please. Thank you so much.
Thank you, Girisha. આપણે વાત કરી બધું બરોબર છે. મેં હમણાં જ મારું સાહેબ જુઓ, મેં સ્ત્રી સાહેબ જુઓ, મેં આપણા હમણાં મારું કરાવ્યું છે નગરી હોસ્પિટલમાં જઈને. આ અત્યારે સ્કીમ વોલેટરી છે, પણ ભવિષ્યમાં કમ્પલસરી થઈ જશે. એન્ડ ઇટ ઇઝ વેરી વેરી નેસેસરી ફોર અવર હેલ્થ રેકોર્ડ્સ. અને આખી યુનિક છે આ વસ્તુ. તમે ગમે ત્યાં સાહેબ કે કાશ્મીરમાં જાઓ કે તામિલનાડુ જાઓ, આ તમે હેલ્થ કાર્ડ તમારો બતાવો, તમારો બધી ડિટેલ આમાં આવી જાય તમારે. એટલે તમને કોઈ ક્વેશ્ચન પૂછવાનો વખત જ આવે.
Absolutely, sir.
Thank you, sir. Now I request Dr. Manoj Kara to give moment to Dr.
Actually, we have to feed that data or
સાહેબ અત્યારે 2 મિનિટમાં મેં કરી અત્યારે જ કરી
થઈ જશે ફીડ ને આપણો ડેટા કેવી રીતે
હેલ્થ રેકોર્ડ માટે
પછી ફીડ
હેલ્થ રેકોર્ડ માટેનો પ્રશ્ન છે તમારો કરેક્ટ there are two ways
તમારે ડેટા જમા કરી શકો છો આધાર નંબર ને તમારો હોય મોબાઈલમાં બધું
એ આભા નંબર જનરેટ કરવાની માટેની છે આપ સાચા છો જે હેલ્થ રેકોર્ડ માટેની આપ વાત કરો છો there is a legacy data say for example મારી પાસે જૂની ફાઇલ છે દાખલા તરીકે મારા મમ્મીના જૂના ડોક્યુમેન્ટ્સ છે હેલ્થ રેકોર્ડ્સ છે એક્સ-રે છે સીટી સ્કેન છે I can always scan it and upload it in my digital locker. જે જૂના લેગેસી ડેટા છે, જે નવા ડેટા છે અને જેની સિસ્ટમ ઓલરેડી ABDM અનેબલ્ડ છે. સે ફોર એક્ઝામ્પલ એપોલો છે, સ્ટર્લિંગ છે, અથવા તો અમારી જે 19 હોસ્પિટલની હું વાત કરું છું. તો ત્યાં જો પેશન્ટ જશે અને એનો હેલ્થ રેકોર્ડ જનરેટ થશે તો એ ઓટોમેટિકલી આ ભાષા સાથે લિંક થઈ જશે. So you don't need to key in additional thing. It is a by product. અમારા જેટલા પણ સ્કીમ ગવર્નમેન્ટના ચાલે છે હું મારા સ્ટાફને હંમેશા કહું છું કે તમારે આભા માટે કામ કરવાની જરૂરત નથી. ઇટ ઇઝ યોર બાય પ્રોડક્ટ. તમે છાશ ઓલવો છો તો એ તમારું માખણ છે. માખણ માટે તમારે અલગથી મહેનત કરવાની જરૂર નથી.
ઓકે થેન્ક યુ
સર જૂના ડેટા અંદર એડ થઈ શકે કે ના થઈ
યસ એબ્સોલ્યુટલી થઈ શકે.
સ્કેન કરવાનું કહ્યું
આમાં થઈ શકે કે પછી ડિજી લોકરમાં
આભા મારફતે તમારા કોઈ પણ હેલ્થ લોકર હોય ડિજી લોકર દાખલા તરીકે ગવર્નમેન્ટનું એક ડિજિટલ લોકર છે પેટીએમ નું પણ પોતાનું ડિજી લોકર છે તો તમે ડિજી લોકરમાં સ્કેન કરીને અપલોડ કરી શકો છો એન્ડ સેમ મે બી અવેલેબલ બેઝડ ઓન યોર આભા નંબર વિથ યોર કન્સેન્ટ એટ એની હોસ્પિટલ ઓર એની ક્લિનિક. સાહેબે જે વાત કરીને હું તમને એક નરેટ કરું મારો પોતાનો જ ઇન્સિડન્ટ છે. એક ટીમમાં અમે લોકો આંધ્રપ્રદેશ ગયેલા હતા અને શ્રીશૈલમની બાજુમાં એક દૂરનું એક ગામ હતું વેર કનેક્ટિવિટી વોઝ અ ચેલેન્જ અને આઈ વોલન્ટિયર્ડ ઇન વન ઓફ ધ પ્રોગ્રામ મેં મારો આભા નંબર આપ્યો અને આઈ વોઝ નોટ વેરી શ્યોર ઇફ ધ ડેટા વિલ બી અવેલેબલ બટ they key in આભા નંબર and my data was available there. Though there was difficulty in communicating with the physician there, he was able to get my data, get the health profile of Pruguras Trivedi. So this is the beauty of technology. આપણે મદ્રાસ ફરવા જઈએ મરીના બીચમાં નાવા ગયા અને શરદી ઉધરસ થઈ ગયા હોય પોસિબલ છે કે ત્યાં જે ડોક્ટર છે એને કદાચ આપણે કમ્યુનિકેટ સારી રીતે ન કરી શકીએ, બટ બેઝડ ઓન ધ ડેટા અવેલેબલ વિથ ધ ડોક્ટર he may be able to treat કે ભાઈ ભૃગુરાજ ત્રિવેદી છે તો ભાઈ એને બીપી છે કે એની શુગર છે કે એની so on and so forth.
You are right.
Thank you so much for providing the opportunity. It was wonderful interacting with you. Thank you so much.
એટલે ફ્યુચરમાં છે ને દરેક જણે કમ્પ્યુટર રાખવું પડશે, કારણ કે નહીતર એ અઘરું પડશે. દરેકે દરેક પેશન્ટ લઈને આવશે કે મારો આભા નંબર આ છે, તો એ આભા નંબર ઉપરથી જૂની હિસ્ટ્રી તમારે જાણવી હોય તો તમારે એ તમારું પીસી કે ગમે લેપટોપ વાપરતા હશો તો જ તમે જોઈ શકશો.
એટલે સર વન ક્વેશ્ચન કે આપણી પાસે ક્લિનિકમાં કમ્પ્યુટર છે, બધું છે, તો પેશન્ટ સ્કેન લાવે તો ક્યાં કરવાનું? આપણી પાસે સોફ્ટવેર આવવાનું હોવું જોઈએ.
આપણે તમારી પાસે ABDM અનેબલ સોફ્ટવેર હોવું જોઈએ. તમારી પાસે ઓલરેડી કોઈ સોફ્ટવેર હોય
તો એને આપણે
ABDM અનેબલ કરવું હોય તો એ પણ થઈ શકે.
તો એ કોની સાથે સંપર્ક કરવો?
1.5 મહિનાથી 2 મહિનાનો ટાઈમ છે. યુ કેન એપ્રોચ આર સ્ટેટ ટીમ એટ એની ગિવન પોઈન્ટ ઓફ
એટલે આપણે કોઈ બી સોફ્ટવેર યુઝ કરતા હોઈએ એને આવા એનેબલ
કરી શકાય, બિલકુલ કરી શકાય.
એટલે આવા ગવર્નમેન્ટ તરફથી થશે કે સોફ્ટવેર વાળા કરશે?
સોફ્ટવેર વાળા ઇટ ઇઝ અ ફાઇન ટ્યુનિંગ.
ઓકે.
તમારે થોડું એને એડજસ્ટ કરવું પડે. એ એક્સચેન્જ ઓફ ડેટા છે, ત્યાં 10 પેરામીટર છે, આ સિક્વન્સમાં તમારે ડેટા આપવાનો છે. જો એનું પ્રોડક્ટ મેચ્યોર હશે, ટીમ સારી હશે તો 1.5 થી 2 મહિનામાં એ આખું પ્રોસેસ છે કમ્પ્લીટ થઈ જાય છે. એનું ટેસ્ટિંગ ફેઝ હોય છે, અલગ અલગ એના ટેસ્ટિંગ સિનારીઓ હોય છે, એન્ડ વન્સ દે આર સેટિસ્ફાઈડ ધેન એના 3 સ્ટેજ છે, M1 M2 M3. પહેલા આભા જનરેટ થાય, પછી એનું હેલ્થ રેકોર્ડ્સ લિંક થાય અને પછી ડેટા એક્સચેન્જ થાય. તો એ ગ્રેજ્યુઅલી પછી એને ફોટો પાડીને અત્યારે પણ આપણે લિંક કરી શકીએ. આભા નામની એપ છે, તમે પ્લે સ્ટોર પર સર્ચ કરશો, એપ સ્ટોર પર સર્ચ કરશો તો મળી જશે. ઘણી બધી PHR એપ પણ છે, એના મારફતે
અત્યારે દરેકે પોતાના પેશન્ટના ફોટા પાડીને મૂકવા પડે.
જૂના જે છે નવામાં તો તમારું ABDM કમ્પ્લાયન્ટ હશે.
આ સાહેબ લખે છે એમનું નવું પ્રિસ્ક્રિપ્શન પેલા પેશન્ટનું, તો પેશન્ટને ચડાવવાનું કે આપણે ફોટો પાડવાનો?
એમનું ABDM અનેબલ હશે ને, એમનું દાખલા તરીકે રામજી એન્ડ સન્સનું કોઈ એમની એપ્લિકેશન છે જે ABDM કમ્પ્લાયન્ટ છે, ABDM અનેબલ છે રાતે, તો એમાં એમને કોઈ ફોટો પાડીને અપલોડ કરવાનું નથી. એમને લખ્યું કે ભૃગુરાજ ત્રિવેદી, પ્રિસ્ક્રિપ્શનમાં લખ્યું પેરાસિટામોલ ફલાણા એમ, તો એની મળે લિંક થઈ જશે. જો જૂના હશે તો એઝ અ સિટીઝન આઈ નીડ ટુ ટેક અ ફોટોગ્રાફ એન્ડ અપલોડ.
એ પેશન્ટ જાતે કરશે, આપણે ડોક્ટર
જૂના માટેની વાત છે.
જૂના માટે પેશન્ટ કરશે.
આપણું કોઈ વધારાનું કામ થતું નથી. ઇટ ઇઝ અ બાય પ્રોડક્ટ.
Thank you, Kirili sir. I request Dr. Manoj Korwai to facilitate Mr. Kirili sir.